this is the scheduled meeting of the Joint Standing Committee on Health and Human Services. We'll be looking at 3 bills this morning and 4 or 5 bills this morning and a number this afternoon. If you'd like to watch, you could go to legislature.maine.gov and look for our YouTube channel under Health and Human Services, HHS. All of this is recorded, so you can go back and see anything you've missed if you'd like to. We'll be taking testimony from people who are in favor of a bill after it's introduced. Then we'll be hearing from the folks who are opposed, and then later from the folks who are neither for nor against. We ask that your testimony be limited to 3 minutes. We have timekeepers who will give you a heads up at 30 seconds. We'll go through the bills in the order in which they're published, starting with 1171 and keep going from there. My phone is off. And we have on a daily basis encountered some sort of technical challenges. So be patient with us and while we try and sort those out. It's been happening very regularly. So we give people a heads up for that. And then we can go ahead and introduce the folks who are here. And we'll start with Representative Griffin.
Good morning. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Cascade.
Welcome. We're also here from Representative Craven.
Thank you, Mr. Chair. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Lemelin. Oh,
Good morning. I'm Michael Lemelin. I represent House District 88, Chelsea, Jefferson, Whitefield.
So Representative Lemelin, just so that you're aware, your feed is a little shaky. So I just want you to have a heads up about that. Representative Javner.
Good morning. I'm Representative Kathy Javner, and I represent House District 141, which is located in Penobscot and Washington counties.
Senator Moore.
Good morning. I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Meyer.
Good morning. Thank you, Mr. Chair, and welcome to all who have joined us here today. I am Representative Michelle Meyer, serving Southern Maine's House District 2, which is all of Elliott and parts of Kittery and South Berwick.
Representative Zager.
Good morning. Thank you very much, Mr. Chair, and everyone. Sam Zager, District 41 in Portland.
Representative Perry.
Oops. Good morning. I'm Representative Ann Perry. I represent House District 140, which includes the towns of Indian Township, Davyville, Barron, Calais, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
Representative Madigan.
Good morning. I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
I think that got out of all of the committee who's here right now. We'll catch up as we go along. And I'm Ned Claxton. I represent Senate District 20, which is Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. Our staff today, our analyst is Ms. Broom.
Hi, I'm Anna Broom. I am one of the legislative analysts for this committee, and I work for the Nonpartisan Office of Policy and Legal Analysis.
And the clerk who keeps us all organized is Ms. Withy.
Good morning. My name is Carrie Withy, and I'm the clerk for the Health and Human Services Committee.
And it looks like Representative Gramlich is here to present her bill. So why don't we make sure that she's in the room, quote unquote. This is so strange that she's on the screen. And we'll let her present her testimony. The floor is yours, Representative Gramlich. Thank you for being here.
I just have to get my video on. Let me just see here. Pardon me.
Take your time.
I just don't Hi.
There, hello.
Whoa, here we are. Well, thank you. Thank you, Senator Claxton and Representative Meyer. And I'll jump right in. Good morning to the rest of my distinguished colleagues of the Joint Standing Committee on Health and Human Services. I am Lori Gramlich, and I represent House District 13, which is the lovely seaside community of Old Orchard Beach. I am honored today to present LD 1173, which is a resolve to develop a plan to treat in Maine those children with behavioral health needs currently treated outside of the state. I will refer to this bill as Bring the Kids Home again, or more accurately still. We are all painfully aware of the crisis that exists in our community-based mental health system for children as well as for adults. A licensed master social worker working in the social service and nonprofit sector, as well as for state government in the Department of Health and Human Services here in Maine for over 35 years, I have dedicated my entire professional career to advocating for children and to assuring that both children and adults have the behavioral health services they need and deserve. This bill, LD 1173, addresses one piece of that crisis: our need to provide the best care for our children who need community-based residential and in-home mental health care right here in Maine with their families. Currently, there are more than 78 children who have been placed out of state for behavioral health care services. These are children placed in Massachusetts, North Carolina, and even as far away as Missouri, Illinois, Arkansas, and Utah. And clearly, these numbers continue to rise. 2 years ago, when I was before this committee, I presented a very similar bill to bring these kids home. At that time, there were about 61 kids placed out of state. This past summer, there were 64 kids placed out of state, and now, presently, there are 78 children placed out of state. That is 78 kids too many. That is 78 families who cannot see their children. That is 78 treatment plans that will never be truly successful because parents cannot be an active partner in these care plans because these parents cannot see their children. And at least, as importantly, these children, they can't be with their families and with their parents. It's really heartbreaking. When we talk about these services children are receiving in residential placement, the common thread for any organization includes treatment plans, as I've discussed, and therapeutic interventions, including family therapy and support with family reunification as a primary focus of this treatment with staff and families, all working together to create a safe discharge plan in a timely manner. Again, as you can imagine, it becomes nearly impossible to achieve this objective when a family living in Maine must get to Arkansas or Utah to not only see their child, but to be part of their treatment plan as described above. As a parent, I cannot begin to imagine the anguish of having my child, who is in need of not only therapeutic behavioral health care, but also in need of her parents, to be placed so far away from our home state and the people she loves. What is even more difficult to fathom is what it must be like for that child, being so far away from her parent or guardian, her support system. And certainly COVID has exacerbated this. Even if a family does have the means and financial ability to travel potentially great distances to see their child, the global pandemic has prevented such travel, and thus the implications of families being separated are sadly more universal. When I presented this bill last session, this committee did indeed pass it, but without the funding mechanism to provide care for these kids right here in Maine. And as you know, I presented a bill last week to address the funding mechanism, which includes rates and reimbursement of rates. This bill that I presented last session, LD 984, was amended to require that the Department of Health and Human Services negotiate reimbursement rates with providers to provide services to children returning to the state, including deviating from reimbursement rates established by the department rules in order to access additional services. The idea was that the department would make a plan to bring these children back home to Maine. I am not entirely certain if the department indeed negotiated rates with providers to assure services would be provided here in Maine. The increased numbers of kids placed out of state would lead one to believe that this was sadly not accomplished. During the 129th legislature, there were plenty of families who told this committee of their firsthand lived experiences of what it's like for them to have their children receiving behavioral health care so far away from them. Uncertain as to whether this committee will have the opportunity to hear from these families, I've attached for your reference news articles that chronicle some of these family stories. Again, this bill first and foremost requires that the Department of Health and Human Services make a plan to bring these children home. Over a decade ago, we faced the same problem and discovered that it was way more costly to have these children out of state than it was to give local providers the resources and tools they needed to serve these kids here in the state of Maine with their families and with their support system for recovery. It is only after more than a decade of flat funding and failure to support our community systems that we have found ourselves in the exact same position as we saw ourselves in over a decade ago. Sending kids out of state at a far greater cost than it would be to keep them right here in Maine, close to their families. According to 2019 figures, sending a child out of state costs on average approximately $210,000 per year. That's per year per child. Serving that same child with the same needs, with the same types of services right here in Maine costs an average of about $160,000 per year. We can all do the math. That's approximately about a $50,000 per year per child savings. And if a child needed additional support services that they weren't currently able to get in Maine, that cost differential would certainly more than pay for that. It is clearly more cost effective to provide services to kids right here in Maine. And to be clear, LD 1173 is pretty simple in that it requires the Department of Health and Human Services to make a plan to bring these kids back home and to inform you, the Legislative Policy Committee, the Committee of Jurisdiction, to be informed as to what that plan is. Please, let's bring these kids home. It's best for the kids, it's best for our taxpayers, and it's best for our families. I urge you to pass 1173. Really appreciate your time. I know how challenging it is to tackle these very difficult issues that are presented before you. Appreciate your consideration of this critically important issue, and I would be happy to try to answer any questions for you. Appreciate your indulgence.
Thank you, Representative Bramlett, for bringing this forward. Are there any questions of the representative? You could help me understand what you think of as the biggest gaps in services that are missing currently to allow these kids to come home.
With respect, Mr. Chair, I wouldn't necessarily say it's gaps in services in so much as the services that are provided that a child would need, we're not adequately able to give to these children because we're not paying our providers enough money to employ people, to keep them doing these jobs. These are generally behavioral health specialist jobs that that young people get once they graduate with a bachelor's degree in social work or a related field. We're paying them barely minimum wage. It's very, very difficult work. And for some of these children who have needs that require more specialized skills and training, we're not providing the opportunity for providers to deliver these services to these children. And so it becomes a more attractive resource to send these children out of state, again, at a higher cost to get these types of services that we really, truly, I believe, can deliver to these kids right here in the state of Maine. I mean, the bigger picture piece, Senator, is that, in my opinion, some of these residential placements could certainly be avoided if we made it a priority to put in some prevention-based work. As I spoke about last week in a piece of legislation presented before this committee, home-based community wraparound services for these children is one of those examples of prevention-based services that could certainly, again, prevent a child from having to have residential treatment. But we don't do that. We don't do that here in Maine. We don't provide those types of community wraparound services for children, and might I say for adults either, while we're at it. And so certainly for this issue with children, we end up meeting the end of the road with kids who end up having really significant behavior issues that could have been avoided and are now in need of residential treatment. That's a very long answer to your short question, but it's a complicated issue.
it was a complicated question in the answering. I knew that. Representative Javner.
Thank you, Senator Claxton. I just have a question concerning whether or not the department has submitted, or if the department will be having their testimony. I didn't know if I missed an email somewhere where it came separate, because I don't see it listed underneath the testimony. That was all. Wondering if I missed something.
Representative Madigan.
Thank you, Mr. Chair. Thank you, Representative Gramlich, for bringing this forward. And I don't know if you're the correct person to ask for this information, but anyone out there in the ether that hears this, do we have information on those 70-something children that are now being treated out of state? I don't want any identifying information, but I guess I'm looking for if they come from counties where there's a lack of community-based services that could have impacted their ability to get some help before they got to the level of care that required inpatient or residential outside of the state. So I don't know if that's information you have, Representative Gramlich, or that's something you can lay your hands on, or.
Thank you for the question, Representative Madigan. I did have that kind of data when I presented, I feel like Groundhog's Day, when I presented this very similar bill to this committee last session. And I did get from the department at that point in time a breakdown of services as you're requesting in terms of by county. I mean, I think anecdotally we know that there are less services available in our more rural counties throughout the state. So that certainly does provide a variable in terms of what we're able to give to these children. I did make some requests to the department more recently in terms of not only how many kids are currently placed out of state. I wasn't able to ascertain if there was indeed a plan that had been developed in terms of bringing these children home. But my understanding is that out of these 78 kids, it's a mix of both children who are in department custody as well as for whom still have are in their parents' custody. So that would be, I think, an interesting data point for the committee to examine. Not that it would change the outcome, because I think all the kids should be home regardless of the custody status. But certainly, I think for the work session, that would be some really relevant data that the committee would want to take a peek at, because we know that certainly in Cumberland County and in some parts of York County and Androscoggin County and Penobscot, where we talk about the service center areas with Bangor and Lewiston and Portland and Northern York County, there are certainly more resources available. Not so much in Aroostook County or Penobscot or Somerset or Sagadahoc or some of our certainly Washington County and some of our more rural counties where we just don't have the resources. But that would not be something that would prevent or inhibit us from making a plan. And what this bill calls for is for the department to make this plan, present it to you. There's an emergency preamble on the bill, so that the department would notify you, the committee of jurisdiction, as to what that plan is. And I would further suggest that stakeholders and vested parties who are boots on the ground doing this work be involved, because they're going to really know best. They're the experts in their own field, right? In terms of the work that they do, they're going to know best how they can meet the needs of these children who present very unique challenges, regardless of where they live throughout the state.
Representative Craven.
Thank you, Mr. Chair. Thank you, Representative, for keeping this in front of us. I think it's so important. So it seemed to me that we have a lot of available beds because of the shortage of staffing and reimbursement for providers. But is it a lack of skilled providers that causes the kids to be placed out of state to begin with?
I don't think that it's a lack of skilled providers. I mean, I think when folks graduate with their various degrees, and by the way, some of these folks providing these services are not, and I'm not trying to minimize or negate the importance of any educational background, but some folks have master's degree in higher education. So I don't know if it's necessarily a lack of skills, but it certainly is difficult to compete. Having a 20 or 30 something college graduate having an opportunity to work at Kids Peace, for example, up in Ellsworth for minimum wage when they can go down the road to Bar Harbor and make 3 times as much money working in a restaurant. People have to pay their student loans off. They have to pay their rents and mortgages. Utility rates increase. Everything has increased except for rates to providers. And if providers don't get the rates that they need in terms of reimbursement, they're not going to be able to afford to pay these skilled workers. So it's kind of a chicken egg scenario or dog chasing the tail scenario. I'm not sure entirely which comes first, but I think Maine does a really fine job in our higher educational system in terms of educating folks that have the skill set to provide these types of services. Where we're dropping the ball is making sure that providers can stay afloat and paying for their staff to provide these services to these very, very needy children who deserve to be home.
Are there any other questions of Representative Gramlich? I don't see any, so thank you again for bringing this forward. Next, we're going to hear from Ms. Mahoney and then Ms. Bickford. But Ms. Mahoney, can you unmute yourself and join us? Welcome.
Good morning. Can you hear me?
We can.
Okay. Good morning, Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. My name is Betsy Mahoney, and I'm the Community Outreach Coordinator for the Autism Society of Maine. I'm also the parent of a 29-year-old with autism, intellectual disabilities, and a mental health diagnosis. I'm testifying in favor of LD 1173 because, as Representative Gramlich pointed out, it's a Groundhog Day. We've been dealing with this problem for many, many years. And as a matter of fact, I'm going to try to move quickly because I know this has been discussed quite a few times. But the problem of people being out of state, receiving treatment out of state, is actually getting worse. As Representative Gramlich pointed out, the Office of Child and Family Services reports that 2 years ago, there were 50 children receiving residential services out of state. Now there are 78 individuals, which is a 56% increase in just 2 years. And then conversely, the waiting list for children awaiting community-based treatment, in other words, non-residential for behavioral health, are growing. And I want to just say as an aside, there was a question about statistics about the out-of-state treatment. In my testimony, I have a link to the Office of Child and Family Services report, which I found extremely helpful. It's all broken down by county, how many people are receiving services, how many people are on the wait list, and how long the average number of days somebody spends on a wait list. So I encourage you, if you have any time, to take a look at that. Again, the need for behavioral health services for children with special needs has grown, partially in response to the pandemic, and will continue to do so. Matthew Siegel, Dr. Siegel, who's the director of the Center for Autism and Developmental Disorders from Maine Behavioral Health, presented to the Autism Society last month on the topic of mental health, the pandemic, and youth with autism spectrum disorder. He noted that young persons with autism are more likely than others with intellectual disability to have a mental health diagnosis. He also explained that kids with autism have a general intolerance of uncertainty, increased rates of anxiety, and impaired emotional regulation. During the pandemic, youth with ASD are extremely vulnerable because they're often unable to anticipate, to cope with, and to recover from the impacts of totally disrupted routines. He noted that as a result of the pandemic, there's been lost school supports, IEPs that haven't been followed, in-home supports lost or reduced. There's also been increased access to therapists, psychiatrists, and developmental pediatrician. As a result, visits to the emergency room due to behavioral crises have increased. 3 out of 15 children with ASD in day treatment programs have been psychiatrically hospitalized within 6 weeks of the program going virtual. Most importantly, the wait list for Spring Harbor's Hospital's Developmental Disorders Unit, which is a residential treatment program, has increased from anywhere from 0 to 3 at any given time. Now it's at 12 to 15 people waiting to get in there, children waiting. So as I said, I would just want to echo a lot of what Representative Bramlett said. This is one piece of the puzzle. And the problem is, though, it goes up and down. In other words, if somebody isn't getting the community-based treatment because there aren't enough providers, then generally, as Dr. Siegel explained, they're going to be much more likely to go into crisis and end up in an emergency room and then potentially need residential treatment. By the way, a link to his presentation is also in my testimony. So I would just say that, it's frustrating because the Long-Term Care Workforce Committee did a great report a couple of years ago, made recommendations. This committee had a bill that they were endorsing a lot of that. So some of this is because of the pandemic, but it seems like we're moving backwards, not forwards. And so the Autism Society urges this committee to vote ought to pass on LD 1173. Thank you.
Thank you, Ms. Mahoney. Are there any questions for her? I don't see any. Thank you for being here. Now we'll go to Ms. Bickford and then Ms. Moody. If you want to unmute yourself, Ms. Bickford, and join us. There you go.
Good morning.
Good morning.
Good morning, Senator Claxton and Representative Meyer and distinguished members of the Health and Human Services Committee. My name is Carrie Bickford, and I come today before you representing Pathways of Maine. Pathways has 9 locations throughout the state, including their headquarters at Brunswick Landing, and we are the largest provider of home and community-based treatment in the state. I thank Representative Gramlich for identifying the costly and traumatic issue of children whose need for mental health services has escalated to a point where they have no choice but to find services outside the state of Maine. Not only are Maine children ending up in the expensive residential care, as well as correctional facilities, foster care, homeless shelters, and the ER, which you guys are hearing all these bills now, not only in the HHS committee, as I told you last week, but in other committees within the state, they're also leaving Maine altogether for care elsewhere. This is a direct result of not receiving the critical home and community-based treatment that they need and are entitled to by federal Medicaid statute. And I want to remind the committee that there was a class action suit back in the early 2000s called the Reisinger Settlement. I talk about it often, but we can't forget about this because Maine lost that suit and they paid millions because of the fact that they were out of compliance with giving these services. And we're there again. All of these alternatives of care come at a cost to taxpayers as much as 10 times greater than the treatment that they can receive in their homes with their families. The number has risen to 78 today of those kids who are receiving care outside of Maine. That fact alone is a clear indicator that Maine isn't providing the care and the problem's escalating. Where you put the money is where the kids will end up. Put the money into residential treatment or hospitals, kids are going to end up there, making many of them lifelong consumers of behavioral health services. And if you put the money into out-of-state care, as you can see, that's where the Maine kids will end up, and that number keeps growing. But if you put the money into home-based services, the kids will end up at home with a much greater chance of living independently as adults, completing their high school education and getting and holding jobs. These are not just statements. Studies have shown time and time again that the home-based services are far superior to out-of-state services when it comes to long-term effectiveness at a fraction of the cost. And Maine, we were put on the map for these services. When these started back after the Reisinger settlement, we were known
30
as a
seconds,
leader.
please.
Okay, we don't need to come up with a new solution. We're already there. Home and community-based treatment's the answer. And our reimbursement rates have not kept pace with the rising costs. The rest of my testimony will give you the history of that. And I just hope that this committee can put the pieces together and realize that this is the answer and we must act immediately. And I hope that you will pass 1173 unanimously. Thank you for your time.
Thank you, Ms. Bickford. Are there any questions? I don't see any. Thank you for being here. And we'll go to Ms. Moody. Welcome.
Thank you. My name, as you know, is Kim Moody, and I'm the Executive Director of Disability Rights Maine. I have submitted written testimony. We are Maine's protection and advocacy agency, so thank you for the opportunity to appear before you again today in support of LD 1173. As you heard from Representative Gramlich, there are at least 78 kids now out of state in residential placement, and this bill simply requires DHHS to develop a plan to complete the task it was given by the legislature and by the governor in 2019. DRM supports this effort wholeheartedly and thanks Representative Gramlich for her continued attention to this problem. Unfortunately, though, when we talk about bringing kids home these days, we are often talking about building new institutions for kids. We really, really need to focus on and fund the provision of services in the least restrictive and most integrated settings that we can for our kids. That is, to pay for community-based services so kids can stay with their parents in their homes. That's what the Americans with Disabilities Act requires, but more importantly, it's really what our kids deserve. And so on behalf of those kids who then become adults, we now know institutionalization does not work well. I implore you and the executive branch policymakers to focus on opening up these beds that we need in Maine for these kids that still need residential or inpatient treatment, not by building new facilities, not by building new institutions for kids, but by establishing appropriate and adequate community-based services and supports and funding those for the kids who do not need to be incarcerated in congregate living facilities, but could be served at home. The incentive now is really to put kids into residential treatment because there's no services. There are really no community services, not adequate community services. The providers need the money to create these services, to be sure, but they also need to really be partner with the state to figure out ways to serve kids with the highest needs, but to discharge kids that can be at home with the supports to keep them safe. Sorry. And to help them learn the skills they need to live outside of institutions. I was around when we filed the Reisinger case, but I was also around
30 seconds, please.
When we closed the adolescent unit at AM High. And Maine was committed to keeping our kids in the community, and we've got to return to that. We've got to think about ways to fund services so kids can stay in their homes. That's all I have to say, really. Thank you very much for the opportunity.
Thank you, Ms. Moody. It looks like there's a question from Representative Madigan.
Thank you, Mr. Chair. Thank you for being here today, Ms. Moody. Both you and the previous panelist, Carrie Bickford, referenced the Reisinger settlement. And I'm wondering if you could speak to kind of what were the conditions that led to that, and then what was put in place? How did we get out of that? And I'm asking as someone who's also worked in the field and was around when that case was adjudicated.
Wow, that really taxes my memory.
Bringing it to the work session or sending us something in the meantime?
Oh, I would love to do that. I mean, I think it would be better if I could review some old records. But we finally just had to file a lawsuit because we worked with the state to try to get community services funded. And as you know, it didn't happen.
So if you could bring a summary of that history or send us a link to a summary, that would be great. And we can have that in anticipation of the work session.
Absolutely.
Are there any other questions of Ms. Moody? I don't see any, so thank you for that and for your homework. Next, we're going to hear from Ms. Harper. Welcome.
Hello, everyone. I'm just pulling up my testimony now. All right, great. Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. My name is Laura Harper. I'm a senior associate at Moose Ridge Associates, and I live in Hollowell. And I'm reading testimony today from my colleague, Betsy Sweet, who, as much as she tried, could not move her schedule around so that she could be with you this morning. So these are her words. My name is Betsy Sweet, and I'm here on behalf of the Behavioral Health Community Collaborative, speaking in favor of LD 1173. You have already heard from others that this bill is a second try at bringing home the now 78 children who are in placements out of state. The department was required to develop a plan in 2019, and so far we have not seen it. Nor when you look at the excellent materials and planning the Office of Child and Family Services have done in the past 2 years, do you see it mentioned as a goal or a plan? Having these children placed out of state is a burden on the children and their families. It removes a child from any possible community supports, and particularly in this time of COVID, it has been almost impossible for families to go visit their children. The isolation often exacerbates their condition. It also does not make financial sense. The cost of sending children out of state for placement can be 2 to 3 times as much as keeping them here in Maine. Nor does it or should it require the creation of building a new facility, or there is a move to create new private residential treatment facilities, or PRTFs, when what is needed is adequate support for current PNMIs. The current children's providers could work with the department to meet the specific needs, whether that means more intensive staffing, some structural changes in buildings, or specialized training to address the gaps and levels of treatment. These are all things that could be done to meet the needs for the vast majority of these children. But these changes are not things the department has been willing to invest in. And then when very high acuity children are referred to an agency, they're turned away because the agencies don't have the resources to develop and or maintain the necessary services. This results in the child being placed out of state. Here's what we're asking. Have the department sit down with the advocates, the providers, and the information regarding these children. Ask the question, what would it take to fix this? Then determine what it would take to be able to safely place these children within a current program or residence where they could receive quality attention and treatment. Again, figure out what it would take to fix this problem, and then create an implementation plan to do it. This is what we asked and legislation required 2 years ago. There's no more time, no better time than now to do this. Do it for the kids, do it for the families, please. Pass LD 1173. And I'm happy to take any questions. I'll bring them back to Betsy, and then we can get you those answers for the work session.
Thank you, Ms. Harper. Are there any questions? I don't see any. Thank you again for being here. So now we'll go to Ms. Shaughnessy after she unmutes herself and joins us. Welcome.
Hi, good morning, Senator Claxton, Representative Myers, and members of the Standing Committee on Health and Human Services. I am Mallory Shaughnessy, and I'm the Executive Director of the Alliance for Addiction and Mental Health Services. And I'm here today on behalf of the Alliance to speak in support of LD 1173. As we've been talking about, and as many of you remember, the 129th legislature passed LD 984. It passed out of this committee with an ought to pass as amended unanimously. And the amendment was very simple. I've included that in my written testimony, and I won't read it to you. But the House and Senate read and approved that bill on May 29th, and the governor signed it on June 6th of 2019. That was 671 days ago from today. In June of 2019, there were 58 youth, as you've heard, placed in Maine Care contracted residential facilities out of state. But as of February 2021, there are 78. I could not find the number of children in residential services in state for June of 2019, but in January of 2020, there were 295 youth receiving services in state. As of February 2021, there are 232. I would hazard a guess that the reduction in numbers in the state receiving service is not just because they all were discharged in fine shape. Some of them may have been sent out of state. In these 2 years since LD 984 was signed by the governor, there have been a number of children's residential service homes that have closed. There have been dozens of beds within the remaining homes that have been shut off due to the inability to pay and staff those beds and pay enough to keep people in this very meaningful but hard work of caring for children with intense mental health and emotional and behavioral challenges. We should also note that the Office of Child and Family Services is doing some very good work. They have sought grants and federal funding. They're doing trainings in evidence-based therapies, expanding some of the services offered, and looking at the system of care for youth with a grant that they had starting in 3 counties and hoping to reach all the counties statewide in 4 years. Maine children in need and their families do not have that long. They simply cannot wait any longer. Every day that a child does not get the support and the services they need makes their long-term prognosis worse Every day that a child cannot see their parents or connect with their family makes that child a little bit more detached. It has been 671 of these days since you passed a resolution that instructed the department to, quote, negotiate reimbursement rates as necessary to find providers to return children to the state and their families. They were given the directive to, quote, that
30
they could,
seconds, please.
thanks, deviate from the reimbursement rates established in order to access additional services. There was no money, however, attached to that directive. It has been 671 days and more children are out of state and more treatment beds have closed down. And as you've heard, we're only talking about residential, but the problems in home and community services are vast as well. Wait lists have gone up from 400 to 700. So the state of Maine needs to step up and make a real plan to invest in the future citizens of Maine. Can you tell the department, do your job of oversight and say within 30 days, you need to know what do they need to actually make this happen? What resources do they need from the state, and not just grants that they can find, federal funds that they may find, but money that we can put in, invest in our children's future. That's what they need to do. And I appreciate your time. Sorry I ran over. I didn't quite get through all my testimony, but you have the written testimony. But it has been 671 days.
Thank you, Ms. Shaughnessy. Representative Madigan, did you have a question?
Thank you, Mr. Chair. Thank you, Ms. Shaughnessy, for bringing this testimony forward and describing, I think, in heartbreaking urgency of it, 671 days and how many kids. How will, this bill says, we need to develop a plan to bring them home. How will this bill bring those kids home?
So right now, you've got testimony, I believe, from Todd Landry. He may be speaking as well from the Office of Child and Family Services. They have been doing as good a job as they can do within the resources that they have and that they've been able to find through grants, through some SAMHSA grants, through some local foundation grants, to do some of the work for our citizens. It is a state office and they should be doing work for our citizens. We need to have them do a plan that says, this is where we want to be. This is what we need to get there, not just what federal dollars can we find or what grant can we find. And so we'll move in that direction. The system of care grant that they've got is only allowing them to do 3 counties to look at the system of care, and then over 4 years to expand to all our counties to look at our system of care for our children. They could do that sooner if they had the resources. So this plan is to say to them, tell you, this committee of oversight, what they need to actually do it. And then you need to do your job and push some of that information forward to your colleagues. And we have to resource this to make it happen. It's been 671 days. They do have a plan, but it's a long-term plan and we need a short-term plan. We need to know what they need. Thank you for the question.
So just to follow up, what you're saying is that developing a plan would allow the department to work on kind of what we can do to bring these kids home now, not wait 4 years. I mean, 4 years from now, some of those kids may well be aged out of, treatment services for children. And then they wind up coming and trying to get services in the adult system, which they haven't even
another problem.
Adolescents at that point.
So exactly that, they, like I say, they are doing great work. They really are within the parameters that they can. They are a state agency. They are within a department. They have the resources that they get. And part of that is given to them by the legislature. They can only do what they can do within that. And then they seek funds from elsewhere. They get, like I say, John T. Gorman gives them money, a foundation, they get some from the federal government, but they are a state agency and they have work that needs to be done. They need to have resources to do that. And if they do a plan, they could come back and say, this is what we would actually need to be able to expand home and community treatment, to end the wait list, to provide funding to providers to staff up and open up some of those closed beds. What it would take to retrofit a few residential homes so that they had a more secure environment rather than building whole new structures. What do they need to do to retrofit for some security to bring some of those kids home that really need to be safe from harming themselves or others until they are able to be better stabilized and brought back into the community, which is really back into the community is where we want these kids back home with their families, back in the community. We're just, they are trying, and I give them that. They are looking at increasing some of the rates for the residential services, which are well overdue. And the rate study shows that. So are the home and community treatment. We have not resourced the system. They need to tell you what they need. That's what I'm saying.
Thank you.
Thank you. Are there any other questions for Ms. Shaughnessy? I don't see any. Thank you for being here.
Thank you very much.
I don't see anybody else who's here to testify for. And nobody is signed up to testify against, or neither for nor against. So that will conclude the public hearing portion of our consideration of LD 1173. Is there information from our analysts that we'd like to have available for the work session? Representative Lemelin.
Thank you, Senator. I have a question for Dr. Landry, so I'm wondering if we can bring him up.
Okay, sure. Hello, Dr. Landry. I didn't see you in the wanting to speak list or hand up or whatever. So welcome.
Thank you for the opportunity to be here. We have submitted testimony, and with the approval of you as chair, I'd like to go ahead and deliver that testimony, if I may.
Oh, sure. It was our mistake in not recognizing that you wanted to testify. So go ahead.
Thank you, Senator Claxton, Representative Meyer, and members of the committee. I am Todd Landry. I'm the director of the Office of Child and Family Services within the Department of Health and Human Services, here today to testify in opposition to LD 1173. As you've heard, this bill requires the department to create and submit a plan to this committee within 30 days of the legislation going into effect. The plan would intend to address the department's efforts to coordinate with families of children who are receiving residential treatment for behavioral and mental health issues outside of the state. Our opposition of this bill is really quite simple. OCFS's Children's Behavioral Health Services Division is already hard at work implementing the comprehensive plan that was developed in 2019 with the involvement of families, with youth, providers, provider associations, and others, including some that you've heard from today. In December of 2020, as this we published our annual report on our implementation progress related to this comprehensive plan, including several strategies that we believe will ultimately have a direct impact on the factors that lead a child to receiving treatment outside of Maine. Some examples also include the development of a psychiatric, not private, but a psychiatric residential treatment facility, also known as a PRTF in Maine, given that many children who are currently being served out of state are placed in a PRTF based on their level of care that is needed, and that PRTF level is not present currently in the state of Maine. We also have efforts that this committee is well aware of, I believe, regarding a rate study and updated Maine care policy for children's PNMI services, and implementing a higher quality of care for those PNMIs, with a Maine care rate that reflects the cost of providing that quality residential treatment. The development and writing of a plan envisioned by LD 1173 would take additional time away from the system improvement efforts already underway. We share the goal, OCFS shares the goal of ensuring that children are able to receive the services they need in our state, and ideally within their own communities. And that goal is reflected in the work that has been and will continue to be implemented in the system improvement plan. I would like to take an opportunity, if I may, to address some of the questions and comments that have come up. The resolve, in 2019 that was passed required the department to work with families to develop individualized plans. We have done that. We have an individualized plan for and worked with every single family to develop that plan for every single child placed out of state. We do not share those plans publicly for very obvious confidentiality reasons. We also have a system-wide plan to address this effort. That is the plan that we've given to this committee and shared publicly in 2019, as well as the update in 2020. But I want to be clear, We have individualized plans for every single youth. And those plans have been developed with their families, or if they are in the care and custody of DHHS, it is with their families and our child welfare caseworkers and the child welfare staff. It's also important to note, I believe, that and I'll give you updated numbers, as of the end of March, we have 75 children that are placed out of state in residential facilities. Of those 75, 20 are in the care and custody of DHHS. 55 are in the care and custody of their parents. And their parents, as you would expect and hope, have a significant role in determining where their children are placed and when those children are returned back to the state after their treatment. I also want to be clear as far as what the numbers indicate has been the trend line, at least over the past year plus. In January of 2020, there were 72 children placed out of state. In March of 2021, there's 75 children placed out of state. I also want to be clear, these are not the same kids or youth. Obviously, children are placed out of state, then they come back into the state. Other children or youth may be placed out of state. So I want to be clear, we're not talking about the same exact children, of course. It's also, I think, important to note that of these 75 children that are placed out of state, 67 of them are placed in New England. 8 of them are placed outside of New England. And the last thing I'd like to point out is total children currently in residential treatment, 75 are placed out of state and 246 are placed in state. All of that data is, as you've heard from some on the call, is reported on a monthly basis. I've provided you the March numbers. Some of the information that others have shared is the February data. We generally update our data dashboard around the midpoint of each month for the prior month, which is why I'm sharing with you March data that will be posted in about a week. A couple other things I just really quickly want to point out to conclude my testimony is beginning in late 2019, the OCFS began reimbursing or paying for families to travel in order to participate in the treatment in the facilities where they're placed out of state, or in some cases for long distances, even when they're placed in state. That continues. However, I do want to acknowledge that certainly some of the travel restrictions related to COVID have made some of those travel components much more challenging. But nonetheless, OCFS is paying for that, and we're working with families to reimburse or pay for that travel, including air travel, for those situations where the number of youth are placed further distances and outside of New England. So with that, I'd be happy to answer questions that you may have. Appreciate the opportunity to share with you some information about this, and happy to try to take any additional questions that you may have.
Representative Madigan, do you have a question?
Yes, thank you, Mr. Chair. Thank you for being here today, Mr. Landry, and I want to thank you and the department for all the work you have been doing. I think you and I both know that both of us are people that care about this issue deeply. I'm wondering if you have information on the average length of stay out of state for some of these kids, or any sort of data you know that aggregates a a range of lengths of stays for out of state. That could be something you could bring to the work session. And you also mentioned the psychiatric residential treatment facility kind of plan you're working on. I'm wondering if you can speak to that or also bring some of that to the work session.
Yes, I do not have average length of stay information at my fingertips. Be happy to work on that and get that to you for the work session. We also shared quite a bit of information in our December 2020 update about PRTF, but happy to provide additional information that you may have or you may have questions about. The PRTF, the Psychiatric Residential Treatment Facility, is a component, in my view, that is missing in our continuum of care. I believe roughly 18 to 20 of the youth that are placed out of state because they are meeting the level of need for a psychiatric residential treatment facility. And in order to meet that level of need, that is not something that we can just, go out to a PNMI provider, for example, and say, okay, start providing this level of care and we'll give you some additional funds to do that. You're either certified to meet that full level, including 24-hour nursing care, 24-hour access to a psychiatrist, and some of those components, or you don't. It's not as easy as saying, it's not easy. It is not possible for PNMI to perhaps flip a switch, using maybe a bad colloquial term, to turn into a PRTF overnight.
Thank you.
Representative Zager.
Thank you so much, Mr. Chair. Dr. Landry, I really appreciate the work that you and your officers are doing on the comprehensive plan, and as well as the update that you provided in December on the progress. I also really appreciate Representative Gramlich's bringing this up. I think that this is obviously a really important issue. My question is Dr. Landry, is what do you attribute the increase to over the last couple of years or several years?
Well, a couple of things that I would point out is, and we'll go back and we can go back in that time period and give you the full numbers. Since I have been here in the state, which was mid-2019, so I'm not obviously going back as long as others have, but from mid-2019 to now, I can tell you that that the monthly numbers that I see every single month has been roughly within a relatively narrow band of children placed out of state, generally speaking between 65 and 75. And so I can't really speak to what it was in 17 and 18. I don't have those numbers off the top of my head, but I can tell you from mid-2019 to now, so roughly coming on 2 years that I've been in the state, the numbers have been very, very stable in total. Now, I also want to remind everyone, of course, again, those aren't the exact same individual youth. Youth have come in and gone out of state, come back in state, during that time period. But at least from mid-2019 to now, the number's been relatively stable.
So you don't have the same impression that it was 50 a couple of years ago?
I need to go back and look at that data, Dr. Zager, Representative Zager. I need to go back and look at that data. I don't have it right off the top of my head. I'm very familiar with it from mid-2019 when I joined and came into this role. So we can get you that data. Happy to provide you with that data in the work session. I just don't have it off the top of my head.
I really respect that and appreciate it. If you could, when you do have the data on hand and have opportunity to consider for the work session, I'm interested in your thoughts on what might be underlying any change, if there is a change that you discover.
Sure, be happy to do that.
Thank you, I appreciate it.
Representative Lemelin, thank you for flagging Dr. Landry for testimony, and you had a question?
Yes, thank you, Senator Claxton. Mike, if I recall, Dr. Landry, your December 2020 plan, it included a short-term and a long-term plan?
Correct. So of the 13 strategies that we identified in the 2019 plan that we are working on, some are we believe can be completed in the short term. Others are going to need to be completed in the long term. So depending upon which strategy you're looking at, they're either short-term completion or longer-term completion. Now, I want to be clear. There's been some, I believe, perhaps misunderstanding that when we talk about longer term, we're not talking about waiting to begin that work. We're just talking about some of those longer term strategies are going to take longer to fully implement, while others are going to be, we believe, in a shorter time frame to implement. I also want to say that between 19 and 20, we moved a couple of those around because we recognized once we began work on some of the longer term pieces, we thought we could maybe accomplish those in a shorter term time frame and vice versa. Some of the shorter term pieces that we had hoped to be able to complete in a 2 to 3 year time frame, we were recognizing it was going to take 4 or more years to do that. So you're accurate. Some of those 13 strategies are shorter term, meaning 2 to 3 years in duration to complete, and some are longer term, meaning 4 or more years to complete.
Okay, thank you. The reason I'm asking is the concern of quite a few people who testified here, and I think some of my colleagues, is the short-term part. So I'm wondering if you could give us either now or for the work session a little more detail on what your short-term plan is. That would be very helpful. Thank you.
Sure, I'd be happy to do that both now and in the work session. And so now, as a preview, if you will, one of the critical linchpins that I absolutely agree with some of those who have testified, including, I believe, Representative Gramlich, is the current PNMI rate needed to be looked at and reconsidered. That rate had not been looked at for more than 10 years. We identified it as a significant issue and a challenge. And the department committed to completing that rate study. That rate study is now in comment period from providers before we can finalize it. Ms. Shaughnessy is exactly right. The draft rate study rates are a significant increase versus the current PNMI rates. And I think that's for 2 reasons. One, as I think she would very quickly point out, they haven't been looked at from a rate perspective in over 10 years. And obviously things have changed in the 10 years. But the other key piece of that is we are also moving the PNMIs to meet a higher level of standard, as this committee has discussed with me, from a qualified residential treatment provider standard of care within the PNMIs. That comes with additional costs as well, and the new rate reflects those additional expectations for the higher quality of care. Now, it is my hope that with a higher level of quality of care and a higher rate to accomplish that, and this is all short term, if the legislature approves this as part of its budget considerations, these rates will go into effect this year. And when that happens, I'm hopeful that 2 things will occur. One, we'll see more capacity and more stabilization of capacity of the PNMIs in the state. My hope is that means that some of these children or future children or youth that are being placed out of state will be able to be served in state instead. And 2, the quality goes up so that in fact those children and youth only need to be in that PNMI level of care for the absolute minimum time needed before they can move to a lower level of care, hopefully back home. And so that's the combination of those 2 things is what I'm hoping will happen. So that's a really good tangible example of one of our short-term strategies that we're employing with OMS, our sister agency, in order to make sure that occurs. 2, I believe it was Ms. Shaughnessy's comment, the new rates are significantly higher, and I think that is indicative, as I said, of both of those factors that lead to that higher rate study. And then I'll simply say, I absolutely agree with some of the concerns that others have shared. I certainly would want, and I think all of us would agree, to the greatest extent possible, we want children and youth to be served as close to their home communities and as close to their families as possible. I am not aware of any state in the country where they're able to serve 100% of all of their children in state because of sometimes the very specialized level of care that may be needed. Do I think we can reduce the number through the strategies that we have put forward and are implementing? I absolutely believe that we can. I also recognize that it's going to take some time to do that. And I think our plan attempts to address that from a perspective of short-term versus long-term.
All set, Representative?
Yes, I am. Thank you, Senator.
Thank you. All right. Are there any other questions for Mr. Landry, Dr. Landry? I don't see any. So thank you for being here. And again, I apologize for my inability to manage hands up in the attendee list. So we're doing things slightly out of order. Obviously, Dr. Landry was testifying against. We'll go back to Ms. Cronin here to testify in support of the bill.
Great. Thank you, Senator Claxton, Representative Meyer, and distinguished members of the Joint Committee of Health and Human Services. My name is Nancy Cronin. I'm the Executive Director of the Maine Developmental Disabilities Council, and we're very much in support of this bill. It's simple. This bill provides you the tools to hold HHS accountable, and it provides you with information that you need to identify what systemic impediments exist that prevent us from caring for Maine's children in this state. And this is necessary. I'm not going to read my testimony, you have it, but a couple things. I want to say thank you, Representative Madigan, for asking for the minimum, maximum, and average length of time out of state. And I'd like to suggest that you also look at the type of disability. It's a different issue if it's an individual with serious mental illness as opposed to autism. I'd also be interested in finding out the type of facility. Is it always this higher level PRTF that Dr. Landry was talking about? I'm interested in were children on wait lists prior to actually having to be sent out of state? Could people have, was there opportunities to provide a lower level of service and we were not able to get it? And because of that inability to be able to provide kids what they needed, it escalated. Long-term oversight is really important, and so is ensuring that our children are in Maine. I know you guys have a full slate, so I just wanted to pop in, especially around those that question about whether it's autism and DD and the wait list. And I thank you for letting me pop in and say that. Thank you.
Thank you, Ms. Cronin. Are there any questions for her? I don't see any questions, so thank you again for being here. So we'll conclude again the public hearing portion of LD 1173. And I don't see any other hands up anywhere that I can see. And we'll proceed to getting any questions to our analyst in anticipation of the work session. Does anybody have any questions that we want to direct to Anna or information you need? I don't see any, so looks like not on this one and more work to come. So that will conclude this portion of our morning related to 1173. Next, we'll be hearing from Representative Fecto about LD 1234, and we'll move him into the panelist role. And thank you for being here.
Thank you, Senator. I did not, when I was being transferred, I didn't hear which bill I'm presenting first.
Let's start with 1234.
Good, I like that one a lot more. It's more fun.
The floor is yours.
Thank you, Senator. Senator Claxton, Representative Meyer, and my colleagues in the Joint Standing Committee on Health and Human Services. I am Justin Fecto, and I proudly represent House District 86, which consists of the western and northern portions of Augusta. In contemporary America, the American dream isn't first realized in a fancy textbook or from a powerful lecture. It isn't passed down in the genetic code either. It's from the traditional lemonade stand. Young Americans first realized the magic of entrepreneurship and hard work pays off by providing a product and service, selling it, and reaping the rewards. For me, it was making enough money to treat myself to an ice cream cone at the end of the day. This fun and simple bill adds lemonade stands and other similar stands operated by minors to the eating establishment section in 22 MRSA section 2491. It adds Part D and states a stand on private property operated by a person under 18 years of age for the occasional sale of prepackaged food, baked goods, lemonade, or other non-alcoholic beverages. One of America's favorite lemonades, Country Time, has focused not on turning states blue or red, but yellow by becoming a pro-lemonade stand state. Country Time's legal aid has helped youngsters avoid fines and penalties from head-scratching abuses of power. While I am without Country Time's legal aid today, I've been passionate about lemonade stand laws for many years. So far, there are 16 pro-lemonade stand states. We are not one of them. The ones in our neighborhood include New York, Vermont, Massachusetts, and Connecticut. In a 2018 CNN article, 2 Denver brothers selling lemonade for charity saw their stand get shut down because they didn't have a permit. In Texas, 2 sisters set up a lemonade stand to raise money for a Father's Day present, but they were shut down and fined for not having a permit or health department approval. And in Maryland, fines for permitless stands have reached a hefty $500. This bill is about providing legal protection to an activity that's already considered culturally acceptable in the state of Maine. Who knew that we might all have been breaking the law when we were kids? Please help me balance the state law by saying that if adults can sell marijuana, then kids can sell lemonade. Thank you for your time and consideration.
Thank you. Are there any questions of Representative Fecteau? I don't see any lemonade questions. So that allows us to go on to then LD 1241. And as soon as you're muted, we'll hear your testimony. Unmuted.
Thank you. I just had to pull up the next document.
Okay.
So good morning, Senator, Representative, my colleagues. I'm still Justin Fecteau, and I'm testifying in support of LD 1241, an act to establish more transparency, due process, education, and understanding between the Department of Health and Human Services and certain Maine businesses. The complaint process involving our service industry businesses and follow-up interactions with DHHS and CDC have been incredibly confusing for our business owners. This bill aims to establish a standard operating procedure to establish transparency, due process, education, and understanding between DHHS and certain Maine businesses. This last year, Maine businesses have been faced with a variety of confusing and unclear mandates, as well as communications with and from DHHS, CDC, and DECD, to name a few. Over this time period, I have faced many frustrated business owners and operators in their interactions with the department. I represent the west side of Augusta, so many of these operators were within walking distance of the CDC, but they never felt further away because of the lack of due process they were afforded. While some defended themselves against uneven interactions and false accusations, many became afraid of standing up for themselves because they felt they were not interacting in a system where they had even the most typical of rights when dealing with government institutions. In at least one instance, a CDC employee took it upon themselves to continue the work involving complaints against a business owner on social media after hours. In another instance, the CDC sent the police to a constituent who had a picture posted on social media of them quickly smiling for a picture before donning their mask when they stood up from their table. In another instance, when a municipality employee was delegated the responsibility of reaching out to business owners regarding complaints, that employee failed to inform all of the businesses. I'm sure none of this is a standard operating procedure. When it comes down to it, my district is perhaps the most visited district in the state by CDC employees. Many downtown and nearby businesses were subject to thousands of interactions by CDC employees, which began as mutually beneficial, but eventually soured over time. I blame that on the lack of standard operating procedures in place. I was unable to even informally counsel businesses in my area because there was no standard way of interacting with the department. Others felt uncomfortable with the unprofessional system of emailing back and forth with those in the department. It was unknown if the case was closed or if deal-making continued for weeks and months on end. Others were also left without appropriate ADA representation for weeks or months as they fought to defend themselves and their accommodations. One business in my area received official complaints on a day where they weren't even open for business. Others have been unable to face their accusers, explain their case, and were not given rights to appeal, even when they were following reopening checklists for the specific industry that the passerby must not have known about. Another business in my area was given a science-based accommodation, and then it was taken away by an executive order. All of this happened without being able to transparently see the information, interact with the department in good faith, and business owners knowing and understanding their rights, and then act accordingly to their rights. This shows me and others that there was either no standard operating procedure that there is one, but it is unrecognizable, or that there is one, but it was ignored a majority of the time. This bill contains a few functions. It requires DHHS to establish a standard operating procedure for investigating complaints against establishments licensed under 22 MRSA section 2492 subsection 1. Those places are eating establishments, lodging places, recreational sporting camps, campgrounds, youth camps, public pools, and public spas. It provides that certain information must be shared with the owner or the person in charge of an establishment that is subject of an investigation. Those things to be shared include the name of the complainant, the name of the department employee investigating the complaint, the laws, rules, executive orders, or policies not being complied with, a corrective action plan, possible accommodations as alternatives to requirements, and the appeals procedures. It requires the department to issue a finding with respect to the compliance. It requires any specific or educational materials that are unrelated to the licensing requirements to be identified. It states that if a representative of the department visits an establishment to discuss these materials, advance notice must be provided, and the visit, must take place during ordinary visiting hours. Although it would make more sense that any time to meet outside of the ordinary business hours would be appropriate if both parties consent. It also states that municipalities that are delegated this authority of licensing and inspection by the department are subject to the same requirements. When interacting with everything from law enforcement to school systems, there is a series of standard operating procedures when citizens face institutions. These appropriate standards are put into place to protect both the individual and the state and its employees. Due process, transparency, solid understanding of rights and consequences, and appropriate accommodations and rights to appeal are always the right answer, always. Later this session, the committee will hear a bill that will give DHHS authority to close businesses. I think this bill is a great way to standardize processes before hearing that bill. I hope we can work together, perhaps amend what needs amending, secure the rights of business owners and operators, and establish standard operating procedures, which in turn will improve our department and their relationship with our amazing small businesses. Thank you for your time and consideration. And I apologize when I put this in a PDF. Sometimes the words get smudged together or whatnot. Google Docs, what you're going to do. Thank you so much.
The testimony came out fine that we've received on the website. So thank you for that. Are there any questions of Representative Fecteau related to this bill number 1241? Yes, Representative Javner. Whoops, still can't hear you. There we go.
Apologize, my finger missed the button. Thank you, Senator Claxton. Representative Fecteau, in our committee, we've actually heard quite a bit of this standard of appeals. In your mind, what would that look like in this situation?
Usually I'm never really impressed as a layperson when looking at legislation. However, I think the legislation as it's written is very, very clear. When you look at page 2 of the bill, it really establishes, it requires a solid paper trail. I think it's extremely American to be able to face a government institution, whether you're right or wrong or indifferent, that it's documented. It happens. I mean, I get mail all the time from government institutions when I'm interacting with it. And I understand the CDC was busy. I understand that. We all understand that. We all understand mistakes were going to be made. I'm not here complaining about the minutia, but what I'm trying to address is the larger issue that I just failed to see, and business owners failed to see a standard. And I think being able to see the complaint and being able to face your accuser and work on an understanding, and then having that all drawn out with dates and signatures and all of that, I think that's appropriate. We do it from everything from the post office to intellectual disability accommodations in schools. So.
Thank you.
Thank you.
Are there any other questions for the representative? I don't see any, so we'll thank you again for being here, introducing the bill.
Thank you.
And we have one person who would like to testify against that I see. Welcome, Ms. Silva.
Good morning.
Good morning. Go ahead at your convenience.
Okay, thank you. Good morning, Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Lisa Silva, and I am the Program Manager for the Division of Environmental and Community Health Inspection Program, also known as HIP. I'm here today to provide testimony on behalf of the Maine Center for Disease Control and Prevention, and will be speaking against LD 1241. The department maintains and uses written standard operating procedures that include many of the items included in this bill to conduct its work, including intaking and responding to public complaints. The HIP receives complaints verbally, by email, by phone, or through the HIP and DECD complaint portals. HIP follows up with licensees on the nature of the complaint via a site visit, electronically by Zoom or FaceTime meeting, by email, or over the phone. If complaints are observed during a site visit, the inspector provides education on how to meet the requirements. Many non-compliance issues are corrected on site while the inspector is there. All of the items in this bill are reviewed at the time of the complaint follow-up. Information summarizing the visit is either left with the owner or followed up via email to the owner. HIP inspectors respond on site to over 500 public complaints each year. In 2020 to present, during the COVID-19 pandemic, HIP has responded to over 1,700 COVID non-compliance complaints. According to standard operating procedures and in accordance with 22 MRS 2497, right of entry, the HIP does not announce inspection visits to licensed establishments, even to discuss scientific and educational materials due to a complaint, because inspectors need to observe how an establishment operates under normal operating conditions versus how they may operate after they prepare for a pre-scheduled inspection. Maine's approach to conducting unannounced inspections is consistent with how health inspections are conducted throughout the country, including in every other New England state, because it is the best practice to protect public health. HIP does not release complainant name and contact information per 1 MRS section 402 3B, along with MR evidence 509 A1 and B. The HIP often receives complaints from current or former employees of HIP licensed establishments, as well as the general public. Some of these complaints wish to remain anonymous for fear of retribution or retaliation by former employers or others. The HIP currently accepts all complaints and follows up to determine a complaint's validity before taking any enforcement action with a licensed establishment. In addition, the HIP receives complaint referrals from other agencies whose intake forms state the complainant wishes to remain anonymous. The public needs to retain the ability to file a complaint anonymously. Anonymous public complaints are a key protective measure to ensure that significant public health hazards do not go unreported. Preserving the ability to file a complaint anonymously without fear or retribution provides an important measure of privacy and protection for complainants. In summary, the Maine CDC respectfully recommends this bill ought not to pass because the HIP already has written SOPs that address many of the items in this bill. The department does not support removing the HIP's ability to conduct unannounced site visits, nor removing the protections afforded to a complainant's identity and contact information. These changes would grossly hinder the department's ability to investigate potential health hazards and protect public health through inspection of licensed establishments. Thank you, and I can answer any questions, and I'll be available for the work session.
Thank you, Ms. Silva. Are there, yes, Representative Javner?
Thank you, Senator Claxton. Thank you, Ms. Silva. I'm not seeing your testimony. I did refresh. I apologize, so I don't know where that. But for the work session, I would really appreciate the listing of your SOP according to the complaints and how that works. Thank you.
Absolutely.
Representative Zager.
Thank you, Mr. Chair. Ms. Silva, I really appreciate your testimony and the work that your office is doing to protect public health. But Mike, it does seem to me like that businesses need to know if they're going to be anonymous complaints, that there's a mechanism to make sure that the complaints are legitimate. I know that in other whistleblowing and other circumstances where there are anonymous complaints, there are such mechanisms. Can you please educate me to understand, to make sure that there's not a disgruntled former employee who's reporting something that is not based in fact, or is maybe a stretch of the facts, so that it can be done in a fair manner, the anonymous reporting?
Yes, I understand that. And I wish I could answer that the way you would want me to answer that, but there's really no way for us to know if there is a complaint that's, from a disgruntled employee or someone is trying to retaliate against their employer. That we intake all complaints, and so we follow up on all complaints because we really honestly don't have any way to know this. And it could be a disgruntled employee in history with regard to our intaking complaints for our other rules, but it also could be very legitimate. So there could be, false, you're absolutely right. It could be false complaints, but we sitting here in this office and they're coming into us, I have no way of knowing that. And so we treat everything the same, everybody the same.
Follow up, Mr. Chair?
Sure.
I understand that, and I'm not asking you to adjudicate something before you can adjudicate it. But is there any penalty, for instance? And if there is, are people who are making a complaint advised that it has to be a legitimate complaint and that you can't wantonly make a complaint?
There is no penalty for the complainants. We license our licensees, the establishments, and our authority to issue fines and penalties is for the licensee, not for a complainant.
And to your knowledge, there's not anywhere in statute for any entity to make sure that complaints are legitimate.
I do not know that.
Okay. And I just, for my own understanding of the issue, I really appreciate it. Thank you.
Sure. You're welcome.
Representative Javner.
Thank you, Senator Claxton. So, Ms. Silva, in light of that piece of information there, even, hindsight is always 2020. And I think we all agree that our small businesses in particular have been seriously hit on levels that they have never experienced before. So many have been forced to close, and a lot of times due to these complaints that have been brought forward. Mm-hmm. So moving forward, how do you view speaking, in light of, knowing that hindsight is 2020, what can the CDC and what can we as a state do in the future to protect our small businesses from these certain complaints, that are going to be out there that are not, that don't have any basis and have forced our small businesses, families to lose their businesses and force them to close? How can we prevent that from happening in the future?
No, I absolutely sympathize. I mean, there are licensees, and so, we want them to succeed and we want to support them. And I think your question, it's a larger discussion than myself that would be needed on how to address that and going forward in the future. The executive orders and the DEC checklist, we were charged as a licensing agency to follow up and to, educate. That's our first thing that we always do, is we educate licensees on the requirements that were needed in the executive orders and the DEC checklist. And then future, we would only issue a imminent health hazard finding, which is not even enforcement. It's just saying that, we have to observe that there is non-compliance. We just don't take the public's word for it that, this person is not wearing masks in this establishment. We have to observe that that's happening in order to issue an imminent health hazard finding, or if there's repeated non-compliance, a temporary suspension. So we don't take, for what the public is saying that, this person is in violation and, say that that's true. We have to go in and validate it. So, and that is done either with our health inspectors or with the local health representatives through the Keep Maine Healthy grant, with our law enforcement And also the liquor inspectors helped us out with regard to all working together to try to, stop the spread and see if these complaints were legitimate and had validity. And if so, that is when we would issue enforcement. Unless we had never educated them before, we would always educate first.
Is there a follow-up? Okay. When I called about a local business against whom there had been a complaint, it was their understanding that because there had been a complaint, they weren't eligible for the CARES money. So I got in touch with the department and found out that that was not anything that you had anything to do with and wasn't true. I also learned that there were an amazing number of complaints in general and a very small number of fines or judgments of imminent health threat or
imminent health hazards. Yes, you're correct.
Health hazard, okay. So I was able to reassure them and they felt much better about the process, but we did have to go to bat for them to get that information because it just didn't fall out of the website. I'd love to see some statistics about year-over-year complaints, percentage of those that get investigated by inspection by somebody, and what percentage of those turn into fines and eventually temporary suspensions.
And I do have those numbers as far as the complaints that came in for COVID this past 2020, 2021 to present. There have been over 4,100 complaints total. We followed up, HIP inspectors followed up with 1,700 of them. And our local health representatives that I spoke about earlier, we worked very closely with them because they provided education in their municipalities and they followed up on complaints as well. So they followed up on 2,400 of them.
That's pretty close to everybody.
And then we also fined only 6 businesses. And we issued 21 temporary suspensions and 91 imminent health hazard findings. And out of those 21 temp suspensions, there were 14 businesses that received those.
Okay. Thank you for that. And just as a reference, if you could get those for the work session for 2019.
For 2019. Oh, okay, sure.
Just for perspective. Yeah,
yep.
Thank you. Are there any other questions for Ms. Silva? I don't see any. Thank you for being here. And I did understand that you were going to post your testimony, so we have that for reference for the work session.
All right, thank you.
As well as other things. So I see that Senator Keim would like also to speak to this bill. So welcome.
Thank you and good morning. Yes, I am a co-sponsor and I would like to offer testimony.
The floor is yours.
Thank you. Good morning, actually, Senator Claxton, Representative Mayer, and members of the Joint Standing Committee on Health and Human Services. I am Lisa Keim, and I'm proud to represent the citizens of Senate District 18, which includes Northern Oxford County and 2 communities in Androscoggin. I'm here to speak in favor of LD 1241, an act to establish more transparency, due process, education, and understanding between the Department of Health and Human Services and certain Maine businesses. This bill requires the Department of Health and Human Services to establish a standard procedure for investigating complaints against certain establishments. The bill provides that certain information must be shared with the owner or person in charge of an establishment that is the subject of an investigation, including the name of the complainant, the name of the department employee investigating the complaint, the laws, rules, executive orders, or policies not being complied with, a corrective action plan, possible accommodations as alternatives to requirements, and the appeals procedures. The pandemic presented countless challenges to local businesses, as has just been discussed. Overnight, some were shut down while others were allowed to stay open so long as they followed a strict set of oftentimes confusing guidelines. The Department of Economic and Community Development was overwhelmed, understandably so, and some businesses were left without answers to their questions regarding protocol. I strongly believe that most all Maine businesses were doing their best to comply with state guidelines and keep their customers safe. Yet, with guidelines changing rapidly, it was hard for many to keep up. Adding further distress to small businesses was the governor's reporting mechanism for noncompliance. This reporting portal was and continues to be particularly disturbing. Community relations were being dismantled as government honed a method for us to secretly police one another. A system for neighbors to turn in neighbors anonymously with no accountability. No requirement to discover if the accuser themselves were legitimate. This wreaked havoc on businesses that were fielding increased state inquiries and inspections, all based on short-term, ever-changing mandates. While this bill focuses on DHHS, in working bills that we currently have before us in the Judiciary Committee on which I serve, we have discovered that every department was left to follow up on complaints as they saw fit, and there was no measure of parity between agencies. These complaints registered via the governor's portal were investigated, followed up, or dismissed, all based on an opaque internal decision-making process. Some businesses believed they were unfairly singled out and likely were. Many endured what seemed like relentless inspections and eventually closed for good. Not only is this destructive government process illegitimate, it has greatly harmed the bonds which connect us. And I find myself wondering how we get back to a place of trust in one another, where we align our energy, join forces, and build our state. How do we go back to a sense of community from here? The goal of this legislation is to create standard process that will prevent the government from harming our hardworking business owners through unpredictable oversight measures. When rules and regulations are rapidly changing, small businesses need grace and trust and acknowledgement of them as the backbone of our state, our communities, and our economy. Small family-owned businesses don't have the staff power to spend hours looking up and interpreting the most recent, and in this case, executive orders. Should complaints be made against them, they need clear directions and options for adherence to know their accuser and the process that was followed in ascertaining merit prior to censure. I thank you for your time today and your consideration of the serious issue raised in this legislation. It is something that has deeply affected the businesses in my community. And they have come to me with a lot of concerns all along the way. And it has been me trying to get answers for them as things were very unclear. So I thank you for your time. Happy to take any questions.
Thank you, Senator Kine, for being here this morning. Are there any questions for the senator? I don't see any. So that I don't see anybody else who wants to testify in support or who wants to testify against. I've surveyed all the raised hands. And based on that, we'll finish up this portion of our consideration of LD 1241, the public hearing portion, and see if there's any questions for our analyst. Any questions to go to Ms. Broom before the work session? Representative Jabner. When you're unmuted.
I'm batting a 0 there today. Thank you, Senator Claxton. If possible, I'm not quite sure how we could do this, but the bills and judiciary that were referenced by Senator Kine's testimony, if there's any pertinent information that they have heard already from the CDC in respects to that, if it's possible for us to have that for the work session as well. Any of the data, the numbers, what they've seen as the SOP even. So that would be appreciated. Thank you.
Okay, are there any other questions of Anna? I give you enough to work with? All right. So that'll conclude our, yes, Representative Meyer.
Yes, thank you, Mr. Chair. No questions on or requests from our analysts for additional information on 1241. But did you ask the same question of 1234?
I don't think I did.
So I have some questions for our analyst on 1234.
Thank you.
So what I'm wondering is what are the licensing requirements for a person over the age of 18 to operate a stand on their private property that would sell prepackaged goods, baked goods, non-alcoholic beverages, including lemonade? And I also wonder if the committee might be able to review those licensing requirements of any individual who is looking for a mobile vendor or a mobile vendor's license for selling similar items.
Thank you for picking that up and bringing your questions forward. All right. So I don't see anything else. Is that that we need to do with 1234 or 1241? We'll thank Representative Fecto for bringing those bills forward. And then we'll go on to LD 1091. And I see that Senator Curry has joined us. I assume you're here to present LD 1091 as soon as you're unmuted.
Hello there, Senator Claxton.
Welcome.
Representative Myers. Thank you very much. Senator Claxton, Representative Meyer, and distinguished colleagues of the Joint Standing Committee on Health and Human Services. My name is Chip Curry, and I am the state senator for Senate District 11, which includes all the rural, coastal, and island communities of Waldo County. I'm pleased to present to you LD 1091, an act to improve the long-term outcomes for youth transitioning from state care by raising the upper age limit for voluntary support eligibility. For the past 8 years, I've had the pleasure and honor of working with young adults who are in the care of Maine's Department of Health and Human Services. I work with them as a small portion of my my typical work week or work month, but it's a really wonderful part of it. These are amazingly diverse young people who have great personal strengths. However, the challenges facing our young people who leave care at 18 are also great. Too often our youth are in over their heads and left unsupported for the challenges that come their way. To remind yourself of the challenges of this time, you might think of your own story or possibly that of your adult child. You might recall a situation where you or your child relied on the love, emotional support, or even financial rescue of a family member. As a 20-year-old, my challenge involved paying utilities, a mundane adult thing, but new to me at the time. I erroneously believed that since I had not received an electric bill after many months, maybe I never would. When the power company ultimately turned off the electricity, I discovered that their addressing error did not change the fact that I owed far more money than I had. After an embarrassing conversation with my parents and a no-interest loan, or possibly it was a gift, I can't recall, I was back on track, the crisis was managed, and I had learned an important lesson. For those who age out of care at 18, we expect the transition to adulthood to be far more compressed. We expect a level of self-sufficiency far greater than their similarly aged family-supported peers. With more limited networks of family and friend support, a similarly minor event to mine might have led to the loss of housing and the upending of school and work. Currently, older youth in care here in Maine can choose to extend their care up to age 21 by developing and signing a voluntary extended care agreement with DHHS. This is an individualized plan that seeks to support the youth's developmental needs, promoting independence and seeking to strengthen healthy permanent family relationships and supports. Utilizing federal funds through the CARES Act, the Department of Health and Human Services temporarily extended the eligibility of many supports to young adults up to age 26. This bill proposes to permanently extend the eligibility of youth to participate in voluntary extended care up to age 23. As I stated, these extension plans are individualized and can include several housing options to match the needs of the young adult, including traditional foster care in a family setting, various levels of supervised independent living arrangements, and residential treatment centers. Likewise, these plans can include a variety of supports for education, training, and employment success. Lastly, we know that family continues to be a significant human need for our young people transitioning to adulthood. These plans seek to support the young adults in strengthening healthy long-term relationships with immediate and extended family and other caring adults. Thank you for your consideration, and I'd be happy to answer any questions.
Thank you, Senator Curry. Are there any questions of the senator? I don't see any. So thank you again for being here. I see one person to testify for, and then one for neither for nor against. If that's not right, put your hand up. And now we'll go to Ms. Gerard for your testimony when you unmute.
Hi there. I'm trying to figure out my camera at the second, but if you can't see me, that's okay too. Bear with me.
Underneath, on the bottom left, sometimes there's a stop video with a caret next to it. If you click on the caret, it gives you some options.
There we go. Hi, everybody. And I'm sorry, I'm trying to pull up my notes I had made. Senator Claxton, Representative Meyer, and distinguished members of the Joint Standing Committee on Health and Human Services, thank you for having me. My name is Stephanie Gerard, and I live in Canaan, Maine. I am 28 years old. I'm attending Kennebec Valley Community College in the respiratory therapy program, and I'm also a full-time employee at Maine General as a patient registrar in the ER, and I'm also a former youth in care. I am here today to just tell you how extending the V9 to 23 would be very impactful to others who are currently in the system. Having been a member of a V9 up until 21, I'm now 28, but even telling you how much help it gave me at 21 was significant. At that time, I was able to support myself, and I was able to kind of find myself at the same time. With the added support, I was able to pay my bills on time, but at 23, it would have been so much more help. It would have been help in figuring out and helping organize my bills. It can be tricky navigating adulthood. I don't know about you, but at 18, you think you know everything, and then 21, you think you know more. And even now at 28, now I know I have no idea what I'm doing. So no matter where you are in life, I feel like it takes time and it takes help, and especially coming out of foster care, there are a lot of supports out there, but having that extended V9 to help you with those financial struggles that I feel like a lot of us go through, I can tell you, I can't even count on my fingers and toes how many times I have reached out to the help of those around me, whether it be other YLET members, the Youth Leadership Advisory Team members that I still reach out to, my transition worker, who I am now far beyond her help. I still reach out to her, and I still talk to her to this day. Even the help that Chip has gotten me through, Senator Curry or Representative Curry, I'm not sure what your specific title is, but either way, the help that I have been given by all of these people, even without the financial backing, but to extend it to 23 would make such a significant impact on so many people's lives. It can become very overwhelming not having that support and having to figure it out on your own if you don't have those lasting connections. So I find it so very important that we extend it so that more of us can become more successful and have those supports available to us.
Thank you for that testimony, Ms. Gerard. Question from Representative Madigan.
Thank you, Stephanie, for being here, and thank you, Senator Curry, for putting in this bill. The Waterville area WILAC group meets actually just around the corner from my house, and I regularly go to it before COVID, forced us to change. But I'm wondering if you could kind of explain a little bit. I mean, you talked about like paying bills and stuff, but what are the other things you think that lengthened support would be able to provide for you and your peers?
I think there's a lot of support. I know at 28, I am a full-time employee and I'm also a full-time student. So even having help in navigating school, I'm 28 and I've gotten myself into certain financial predicaments that have made it so that I have to work full-time while being a student, which is really hard. Although no one anticipates it being an easy road, being in a school of a healthcare profession or any profession at that, and also working full time. It's the support behind it and trying to navigate, and also just trying to navigate all these different roads and where can I get help for school and health insurance. And of course, not to mention like transportation. Some of us don't have licenses or cars, or just trying to navigate those typical questions that you would ask other support for. So those of us who have left care without those long-lasting relationships that we try so hard for with foster families and permanency, we might have those routes to look at or those people to look to in order to get to where we need to be to help us become more successful so that we do have an easier time standing on our feet once we age out.
Thank you.
Yeah.
Are there any other questions? So thank you for being here and offering that personal testimony. Oh, there's one from Representative Stover. And you might as well introduce yourself since I forgot when you joined us.
Yes, good morning. My name is Holly Stover. I represent House District 89, including Boothbay Harbor, South Port Edgecombe, West Port Island, and part of South Bristol. And I just wanted to thank you, Ms. Gerard, for being here this morning. I've had an opportunity twice in my life, in my own life, personal life, to serve as a mentor for a young person, 2 different young women who also had aged out of care and pursued college and pursued life and all of the things that we all go through in pursuing life when we start out on our own. And I just commend you. I commend you for being here today. I commend you for working full-time, going to school. There are people who had a tremendous amount of supports growing up who did not grow up in foster care, who are not working full-time jobs and going to school full-time. So if we were in person, I would like to shake your hand, but I just want to say thank you and commend you for what you are doing with your life. Congratulations.
And I feel obliged to comment that as an adult, it sometimes is easier, but sometimes it's harder, and it's a project. Thank you for being here and sharing that testimony. It's much appreciated. We're also joined this morning by Savannah Vale or Valley?
Valle.
Valle. Oh, I'm sorry.
That's okay. Hi. Thank you. Thank you for having me. Hi, Senator Claxton, Representative Meyer, and the distinguished members on the Joint Standing Committee on Health and Human Services. My name is Savannah Valle. I am currently a student enrolled at University of Southern Maine. My major is in psychology, minoring in both sociology and race and ethnic studies. And I am also working full-time as well. I fully support the LD 1019 because as a youth, I am 20 years old currently. So when I aged out of care, the first thing I didn't understand was even enrolling in college. No one has talked to me about that process. I did not know anything about how to navigate young adulthood. And then I was approached with the opportunity in becoming or having the V9 opportunity. And I know that when I aged out of care, I actually left my foster home at 17 and I was homeless for a while. And when I finally got on my feet and realized that there are all of these expenses that I need to pay for, I didn't have as many resources as I wished I did. So fortunately, I got reconnected with one of my caseworkers, and the money that I get from my V9, I'm able to use for food, for needs, like personal needs. I am able to use it for books and supplies, and it has been very impactful towards me progressing and also taking the chance in getting a degree and furthering my education.
So thank you for sharing a portion of your journey. Representative Stover, is your hand up still or again? There we go.
Actually, I would say the same too, and I'm sorry, I'm not going to Ms. Valle. I just want to say the same to you for your courage and your persistence and for doing this, because I congratulate you. It's hard to grow up, and your challenges may have been greater, but you've done it. So I appreciate both of you being here today.
Are there any questions of Ms. Valle? I don't see any, but I do feel obliged to recognize the hard work that both of you have done to get to where you are. So congratulations on that, and good luck the rest of the way. We have one person that I am aware of who wants to testify neither for nor against. So I recognize Dr. Landry at this point.
Thank you, Senator Claxton, Representative Meyer, members of the Joint Standing Committee. Again, for the record, I'm Todd Landry. I'm the Director of the Office of Child and Family Services within the Department of Health and Human Services, here today just to provide you with information on LD 1091. As you have heard, this bill would raise the upper age limit from 20 to 23 years of age, I believe, for voluntary extended care for youth who turn 18 while in the department's custody. The bill also makes a corresponding change to the program eligibility requirements for the Alumni Transition Grant Program, sometimes referred to as ATGP as well. OCFS is currently in the process of implementing a recent and currently temporary change to federal law regarding youth aging out of care. We therefore would recommend no action be taken on this bill until OCFS can implement the current change and gather data on the impact of that change. For more detail on that, this is part of the Consolidated Appropriations Act of 2021 that the federal government passed. As part of that act, the Supporting Foster Youth and Families Through the Pandemic Act was also passed as incorporated. Now, that bill temporarily requires Title IV-E agencies, in this case in the state of Maine, OCFS, to prevent youth from quote-unquote aging out of foster care solely due to age from 12/27/2020 to 9/30/2021. OCFS is, as I said, the Title IV-E agency for Maine, and so we are now in a position of allowing any youth who left care due to reaching the state's maximum age for voluntary support during the public health emergency, January 27, 2020. Yes, January 27, 2020. I'll check that date. It might be 12/27/2020 to April 20th of 21. This is subject to extension by the federal government, I should say. And those youth who have aged out during that time period are allowed to voluntarily re-enter care, as well as those youth who reach the age of majority during that time period. So the federal legislation, also provides funding to support the work that is incorporated in there. And I think that's an important piece to recognize. So OCFS is currently implementing this change. We believe it could make sense to defer any action on this bill to provide time to understand the impact of the change, both from a fiscal perspective as well as for the youth who otherwise would have aged out of care or who voluntarily re-entered care. I will add my comments and supportive comments to Ms. Gerard and Ms. Valle for their work that they have done and continue to do. As you have heard, the challenges for youth who reach the age of majority while in the care and custody of the state is significant and can be challenging. That is why the state some years ago extended the opportunity to be on what is commonly referred to as that V9 agreement through the age of 21. We're not necessarily opposed to increasing that age, but we do believe that the time period that we are in right now gives us an opportunity using federal funds to study the impact of that so that we can come back to you with a more definitive answers regarding the potential fiscal impact and potential programming impact as we learn during this time period of this federal legislation and authority. I will also simply add currently in this group of youth are currently 63 youth who are currently voluntarily participating in this in the extended care component. That includes those who are under the age of or up to the age of 21, as well as those who have temporarily been extended this opportunity through the federal legislation. So thank you for the opportunity to testify before you today. There are a couple of places in this testimony where I think we may have a typo, and so we will work to get that corrected and get you an updated version of our testimony, and we apologize for any confusion related to that.
Are there any questions to Director Landry? I don't see it. It's any that, yes, Representative Perry with the buttons.
Sorry, I couldn't find my button. The question I do have, as you're looking at doing this, is evaluating how this would go using the federal funding. Is that something that we could get report back on, like in January or something? And I'm thinking of putting this bill on hold and seeing if perhaps we can have a sort of an update and to see if this is something we can do.
Representative Perry, from my perspective, we would be happy to provide you with information as well as to Senator Curry as the sponsor of the bill regarding what is happening during this time period. It is something that we think would be valuable for this committee to consider, knowing how many youth participated in the voluntary aspect of the temporary increase in the age expansion, as well as those who voluntarily re-entered care who may have been over the age of 21. We think that will give us some important information about what the potential fiscal impact of this is, because if the state were to extend the age under existing federal law, absent the current emergency provisions, it would be state general fund funded, excuse me. And so we think it is an important aspect for the committee to be able to benefit from that additional information. But this does give us a nice opportunity to test this out, if you will, see what the volume is, what the opportunities may be, as well as any challenges that we encounter that we might need the committee's assistance to overcome in considering legislation.
So your assessment of the emergency provisions, is that work completed within OCFS?
It will be. We have a period of time for us to implement the voluntary age increase, and so that goes until 12/27 of last year, all the way to the end of September. So we have this opportunity for this federal funding for that source during that time period. That includes that shorter time period of 12/27 to April 20th of 21, where those who had aged out before or who were over the age of 21 could voluntarily re-enter. And so there's kind of two pieces going on. One is kind of a catch-up provision, recognizing that it took some time for the federal ACF to promulgate rules and guidance related to the act. So there was this little bit of a catch-up period up to April 20th. And then there's this extended period, at least through the end of September right now, where we have federal funds to use in order to pay for this extension. There is also the possibility, and I would never speak for our federal Congress, of course, but there is the possibility that they will extend it beyond September 30th into the next federal fiscal year. But again, by giving us some time to implement this and study it, we'll be in a better position to come back to the committee with actual data of what we have found during this time period.
And what I was trying to get at is there a point for having a work session down the road before we adjourn that would let us understand what your implementation plans are versus outcomes, which we won't know? And are we adequately covering, without this legislation, we're not adequately covering that time span from 9/30 on without federal largesse?
Both of those statements are true. We'd be happy to share with the committee during the work session, how we are outreaching to potential youth, for example, to make sure they're aware that they have this opportunity to come back into, as I said, the colloquial term is a V9 agreement. And so there are a number of plans that we've put in place, and we can certainly share with you all of those plans during a work session whenever you choose to schedule that. You are also correct that unless the federal government were to extend the current provisions of the Supporting Foster Youth and Families Through the Pandemic Act to go beyond September 30th of 21, there would be this potential gap period. And so that is also true as well.
And how long do you think the department will take to finish up with its implementation planning phase?
Well, we are implementing right now, and so we have we're constantly updating those plans, but we could certainly share with you what all of our existing plans are. But we are constantly updating it as we hear from young adults like Ms. Gerard and Ms. Valle and others saying, hey, it would help us if you would have posted this on some other streaming platform, for example, or it would have helped if you would have posted it. So we're always evolving some of those communication plans, but the main components of our implementation plan are in place, and we're ready to share that whenever you wish to schedule the work session.
That's what I was trying to get to. If you needed any wiggle room when we schedule the work session, and it sounds like the answer is no. So thank you for that. Are there anyone else who wants to speak neither for nor against? I don't see any hands. So again, we'll thank the folks who joined us for testimony, and Senator Curry for bringing this bill forward. Any comments based on what you've heard, sir, so far? You're ready to show up at a work session later on and hear what the department has lined up?
Thank you, Senator Claxton. Yeah, I'm definitely hearing that September 30 deadline of care. I'm also quite aware that we're talking a fairly low number of youth that we're talking about potentially extending beyond 21. And I will tell you in general, my thought on that is mixed. Is like, yay, it would be a smaller fiscal note. But also I know the challenges there. And so that tells me what's the level of our, this is my work around, my background's in this age group, and I've worked in higher ed and the developmental challenges of this age group. And so how do we best deliver the supports so that this launching phase into adulthood is most successful? And so I'm right there working with the department, or wanting to work with the department to figure out how we do this just significantly.
All right, so we can go ahead and schedule a work session. In anticipation of that work session, are there any questions of our analyst? Any information, anything that would be helpful? I don't see any particular concerns, so thank you again, Senator Curry, for presenting this, and we'll proceed to a work session to be determined. Thank you all for being here. That will bring us to hearing LD 854, and that's to be presented by Representative Meyer. Welcome.
Thank you. Thank you.
To your new role.
Yes. Sponsor. Senator Claxton and esteemed committee colleagues, I am pleased to present LD 854, an act to ensure continued school-based services for children with disabilities. The purpose of LD 854 is to protect and preserve medically necessary and educational services for young children with disabilities attending developmental preschool programs throughout our state. It is similar in scope to LD 2141, which I introduced last session. That bill had widespread bipartisan support and passed unanimously out of this committee last summer. It followed a proposed January 2020 main care rule for a new section, 106, which proposed consolidating school-based services into one main care section. After thousands of parents, advocates, and providers raised significant concerns about the rule's impact on preschool-aged children with disabilities, including a reduction in access to full-time, year-round early intervention services, as well as a reduction in rates for those services that are critical to children's long-term development and independence, the department recalled the rule. The previously proposed rule was considered routine technical and would have gone into effect with major flaws had families across the state not advocated for their children and the services they need to ensure they reach their highest potential. I thank the department for its decision to withdraw the proposed Section 106 after the strong feedback it received from families and providers. I understand the need for the new section and that it will be reintroduced. I believe the department is acting in good faith, and so are the providers of early intervention preschool services. We all want the same outcome, that young children receive the services they deserve, that our valued services providers can remain viable, and that the state of Maine authorizes school-based services in the most appropriate way. I do believe, however, that the issues Section 106 sought to address are so complex and involve such critical services for such a vulnerable population that moving forward, legislative oversight is required. LD 854 does two important things. First, it requires that any main care rule changes impacting children ages birth to 5 years of age for developmental preschools be major, substantive, and require legislative oversight. Secondly, it requires DHHS to convene a stakeholder group to actively participate in any rulemaking relevant to school-based services and includes advocates, parents of children receiving services, Child Development Services, CDS, and the Department of Education, DOE, and considers the findings from the independent review of the state's early childhood special ed services being carried out at the legislature's direction. As you know, developmental preschools treat young children with autism, developmental disabilities, intellectual disabilities, and mental health diagnoses. The importance of early intervention services for this population is well documented. Young children with autism and other disabilities need, on average, 30 hours or more of clinical intervention services a week on a year-round basis to make critical gains according to widely accepted evidence-based research and best practices. Despite the research, children in Maine's developmental preschools often do not receive 30 hours of early intervention services through CDS authorization. Providers report CDS typically authorizes children for 6 to 15 hours a week, sometimes more, but very rarely full-time early intervention services. To provide children with full-time services, providers supplement CDS hours with Main Care Section 28 or 65 services and transition the CDS hours to Main Care hours or just rely on Main Care services. Providers have adopted this method of supplementing CDS hours with Main Care hours out of necessity because the treatment authorized by IEPs does not fully meet children's needs. In fact, CDS has a formal expectation with some providers that they have a 30-day transition, that they have 30 days to transition a main care eligible child from CDS to main care services. Section 106, as it was originally proposed, limited developmental preschool hours to only those authorized on the IEP, thus limiting the access to additional and appropriate services needed. Clearly, this issue is complex. It involves DOE and CDS and DHHS. These challenges between the department's efforts to limit medically necessary services to only those that are in the IEPs and determinations about who is going to pay for them have been an issue for well over a decade. It's critical that these departments work together to coordinate the authorization of early intervention services to fully meet young children's needs and design a system that works for all. The department's work to create and implement Section 106 comes at a time when the legislature is considering the recommendations from the Public Consulting Group report and the best way to deliver preschool services to children throughout the state. Because these issues are so complicated, involve multiple departments, and have such high stakes, it's imperative that we keep the legislature involved. Families of children with disabilities in every county and in every one of our districts are looking to us to ensure that they continue to have access to early intervention services. We owe it to them to work with DHHS, with DOE, with CDS, and with providers to get it right. I also want to draw the committee's attention to some corrected bill language that was attached to my testimony. You will see that medically necessary is inserted before all places where school-based services is referenced. And then line 17, which now reads, the department shall support medically necessary school-based services. Just something to have attached to my testimony. I'm happy to take any questions, but as I've attempted to articulate, this is very complex and there are many behind me who are much more equipped to answer detailed questions about this complicated matter.
But Senator Moore has a question for you.
Thank you, Senator Claxton and Representative Meyer. And this may be a question for someone after you, but I'm just curious, what is the definition of medically necessary?
And I'm definitely going to ask you to propose that to those behind me. I could make some statements around that based on my knowledge of that, but I'm going to let the experts give you that information.
All right, thank you.
Are there any other questions for Representative Meyer? Seeing none, we'll go to those who are here to testify in support. I think there are 4. We'll start with Ms. Haskell. Welcome.
Hello, thank you. Good morning, Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. My name is Tiffany Haskell. I'm the clinical director at WABAN. I'm a special education director, school psychologist, and board certified behavior analyst. I've worked with children and families in Maine for over 25 years. WABAN provides services to preschool children with developmental disabilities and behavioral health needs in a clinically intensive school-based program. We offer evidence-based therapies, educational and medically necessary treatment with a team of educators, therapists, and clinicians. I also serve as a member of the Maine Association for Community Service Providers Children's Committee, that's called MACSB, and I'm pleased to offer this testimony in support of LD 854 and on behalf of WABAN and MACSB's members. MACSB is the statewide association of more than 70 organizations providing services for thousands of children, adolescents, and adults with intellectual disabilities and autism to live and thrive in all of Maine's communities. We thank both Representative Meyer and members of the committee for your support of the similar bill that was voted out of the committee last year with bipartisan support. We also offer our thanks to the Office of Main Care Services and the Department of Health and Human Services for their willingness to take a step back to more fully appreciate the complications and unintended consequences that can result when services, eligibility, and rates are redesigned under a new rule involving a number of main care sections and 2 departments, DHHS and the Department of Education, or more principally, Child Development Services. What's at stake is the future of 3 to 5-year-old children with developmental and other behavioral health disorders who require specialized care in clinically intensive preschool programs. These programs offer a range of evidence-based therapeutic and educational and medically necessary services that enable children to make critical gains necessary to support them in their communities and in their life. The proposal of any new main care school-based services rule, which, as mentioned, involves multiple departments and is also at a time when public consulting groups study of the CDS system to the legislature is being considered. It makes this Bill LD 854 more critical than ever. There do exist some inconsistencies in approaches used across the state by CVS in authorizing service hours, and there's a significant reliance on main care funding to meet the needs of preschool children with disabilities in these educational clinical settings. This contributes to a very complicated landscape when considering any changes to the service delivery model for this very vulnerable pre-K population.
30 seconds, Ms. Haskell.
Thank you. These many moving parts, combined with multiple dynamic changes underway, just further underscores the need to establish a very well-organized and visible stakeholder group, as well as a provision in statute to ensure that any rulemaking for these school-based services be deemed major substantive as proposed in the bill. We sincerely look forward to the development of a new school-based services rule. We want to include stakeholder engagement and have it avoid negative impacts to the waitlist and services, and avoid rate cuts to providers of these intensive services, while adhering to a thoughtful understanding of the funding and the complicated system of care to serve this pre-K population. Urge your support of the bill, and thank you for your consideration.
Thank you, Ms. Haskell, for being here. Are there any questions of, yes, Representative Craven?
Thank you, Mr. Chair. I don't have any questions. Nice to see you, Tiffany. Congratulations, and thank you for all of the work that you're doing.
Representative Lemlin?
Yes, thank you, Senator Claxton. My question, I guess, is the same thing Senator Moore asked, and that is, I'm confused about the definition of medically necessary. And I'm wondering if you can explain a little on that. Are we talking about services like PT and OT that might be medically necessary? And is there more?
There are, and I do think that others who will testify will contribute to this answer as well. Kind of in a nutshell, when you think about the difference between medically necessary and educational, kind of on the educational side, you're thinking about reading, writing, and math. And on the medically necessary side, there are lots of services that support a child's ability to receive that instruction or participate in that instruction and to make progress in some basic skills of daily life, which we all need. And children with autism and developmental disabilities need additional support and instruction in those kinds of things like self-help, self-care, communication, behavior management, social skills, and all of the therapies that you mentioned as well, PT, OT, and speech. In particular with 106, the sections that were looking to be collapsed and combined were around Section 65, Behavioral Health Day Treatment, and Section 28, Rehabilitative and Community Supports for Kids with Autism and Developmental Disabilities. And so it's far reaching, but that's a little bit of it.
Okay. I don't see any other questions. So thank you for being here again, Ms. Haskell. And we can go to Ms. Hathaway. Welcome. When you're unmuted, we want to hear what you have to say.
Hello and good afternoon. To the members of the Health and Human Services Committee and to the committee chair, Senator Claxton and Representative Meyer, I am testifying today in support of the proposed bill LD 854, an act to ensure continued school-based services for children with disabilities, sponsored by Representative Michelle Meyer. As you may recall, I presented testimony to this committee approximately 14 months ago in opposition to the Main Care proposed Chapter 106 rule. At that time, in response to the proposed rulemaking, early intervention providers from across the state gathered to inform you of the drastic and detrimental effects that Chapter 106 would cause to an already fragile, fragmented, and dysfunctional system. Although there were pockets of promise within proposed 106 and clear efforts to unify varied needs and language of both the DOE and DHHS, Chapter 106 was fraught with nuanced inconsistency, overlapping requirements, clinical disparity, and perhaps misunderstood application. As providers working knee-deep in the regulations daily, as we work to provide necessary services to the youngest and most needy children in Maine, Chapter 106 posed obvious and significant, even if unintended, consequence. One of the actions taken in response to the opposition and grave concern of providers across the state can be found in LD 854. This bill, as I understand it to be proposed, requires that amendments made to or new rules written for medically necessary early intervention services become major substantive rule. By requiring this consideration, DHHS would need to convene a stakeholder group when drafting new rules and consider findings of the independent review regarding early intervention services within the state. And some of that work is being done. I believe as a provider of early intervention services for 22 years and counting, that this measure is critical for the continued success of and partnership with early childhood providers. With a current and significant statewide shortage of early intervention providers, we cannot continue to arbitrarily change programmatic rules without considering the rampant, significant outcomes of these changes. It is important to note that our support of LD 854 is not in response to the works or efforts of this current administration or because of any particular person or designees acting on behalf of the department. We have seen positive changes in both approach and in communication from this administration and from the department itself.
30 seconds, please.
At the same time, as a longtime service provider, I understand that agencies, services, and ultimately our children should not be at the mercy of ever-changing parties or political power. LD 854 brings a measured and balanced approach to the table, allowing for necessary change and evolution of program and rules while making this change transparent and in consideration of the impact, need, and application to existing programs. I believe that we can be identified as good resource and willing partners, and our intentions are to provide necessary services to a population that is deserving of this. I thank you for your time, your consideration, and your efforts to the state of Maine during this most unprecedented and challenging time.
Thank you for your testimony. Are there any questions of Ms. Hathaway? I don't see any. So thank you for being here. And we'll proceed next to Mr. Tash. Welcome.
Thank you very much, Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. My name is Scott Tash, and I'm the CEO of UCP of Maine. UCP of Maine has been supporting families and serving adults and children with a wide range of intellectual disabilities, mental health needs, and behavioral and/or physical challenges since 1954. And those services currently include services for children birth to 5 years old in both the in-home and community settings, as well as center-based preschool offerings in the greater Bangor area. I also serve as a board member for the Maine Association for Community Service Providers in the roles of treasurer and chair of the Children's Committee. And I am pleased to offer this testimony in support of LD 854 on behalf of our Children's Committee and my specific organization, UCP of Maine. Of primary concern leading to the support of this bill is ensuring the understanding of the specific and specialized needs of the 3 to 5 year old population with developmental and other behavioral health challenges. Each year in our programs, we are referred to and work with children who need evidence-based therapies and focused special education services in order to have the best chance to successfully transition to public schools. Receiving these referrals many times after the child has previously started in more traditional early education or daycare settings, but were unable to be successful in those environments. Programs such as ours and others across the state have been successful in offering these specialized services at levels deemed medically appropriate, preparing the children to successfully integrate into the public school setting. Those needed specialized services may include one-on-one behavioral and/or educational support with behavioral health professionals and education technicians, clinical oversight with LCPC or BCBA individuals, access to speech and occupational therapists, and they're all working directly with and focusing on the specific needs of the child. To fully understand the needs of those individuals, we do engage with a broad team of experts to fully understand, evaluate, and deliver the proper treatment. And it is critically important the department take the same approach and that any new school-based service proposals include proper stakeholder engagement, which, as we've mentioned, would include parents, guardians of the children, current providers, other advocates throughout the state, existing CDS staff, SAUs, and the DOE, to allow for the various areas of expertise to engage and collaborate within a complex system of care. As has been mentioned before, early intervention for this population is critical in setting them up for success as they transition into advanced education settings and beyond into adulthood.
30 seconds, Mr.
And
Tash.
input from these groups of invested parties are all critical in ensuring appropriate levels of services, access to services, and reimbursement for services provided are maintained at levels sufficient to ensure the young children continue to advance their progress, and it does not limit the medically necessary services in any way. Therefore, we fully support the provisions within LD 854 that require the department to convene the stakeholder groups of representatives of providers, advocates, and parents, the CDS system, school administrative units, and the Department of Education, and also that the department rules pertaining to school-based services be major substantive. I do want to thank Representative Meyer and the committee for listening to the concerns of parents and providers last year. And I thank you for your time today, your consideration of your support for this bill, and we stand ready to work with the department, legislators, and other stakeholders on any new school-based service rules that includes that stakeholder engagement and any consideration of potential impacts to such a vulnerable population. Thank you.
Thank you for your testimony. Are there any questions of Mr. Tash? I don't see any. So we've been joined by, but she left again. Miss Bouquet must be having some trouble with her internet connection. She was here briefly. Let's see if she shows up again. Do you know anything about that, Miss Withy? Do you know if she's been having trouble?
I don't, Senator Claxton.
Okay. Well, with the understanding that we want to make room for her to testify should she come back into this, then we'll hear somebody speak against, and that would be Director Probert. Welcome. Good afternoon.
Good afternoon. Before I go into testimony, I do have some information regarding the definition of medically necessary services, if that would be helpful to provide first, or I can also wait and provide that after.
Sure, go ahead.
So we will follow up in writing because there is a lengthy definition of medically necessary in the main care benefits manual, which I am not going to read right now. There is also language from the Social Security Act, the federal level, which may also be helpful. But I will share on a more colloquial level that main care is able to reimburse services that are listed in an individualized educational plan, IEP, that are health related and or that are main care covered services when the IEP team determines that those services are needed for a child to access their education. And most commonly, those services are often speech, physical therapy, occupational therapy, transportation, behavioral, and developmental services.
Thank you for that.
Absolutely. So that I will proceed. Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Michelle Probert. I am the Director of the Office of Main Care Services. I'm here today to speak in opposition to LD 854, an act to ensure continued school-based services for children with disabilities. This bill directs main care to provide coverage for school-based services in developmental preschools for children from birth to 5 years of age. It designates any rules adopted pursuant to this LD as major substantive rules under the Maine revised statutes and requires the department, when drafting those rules, to convene a stakeholder group and take into account the findings from the independent review of the state's early childhood special education services being carried out pursuant to public law. The department initially interpreted the bill to require it to provide direct services already provided by Child Development Services within the Maine Department of Education. We now understand that this is not the intent of the bill and that the bill will be amended to clarify this. MaineCare allows schools and private agencies to enroll as MaineCare providers and to be reimbursed for health-related covered services described in the student's individualized education program that are delivered in school settings to enable children to access their education. Additional services that are not covered by MaineCare may be paid for through DOE, which has oversight of CDS and is the approving authority in Maine for special purpose private schools and programs. MaineCare has continued work on a new school health-related services policy and anticipates being ready to propose a new rule before the end of this year. The department will continue engaging with stakeholders regarding the proposed changes and also intends to delay implementation of the new rule post-adoption to allow sufficient time for education and training before it takes effect. The Office of MaineCare Services supports providing coverage for school-based services in developmental preschools. We understand that there are stakeholder concerns with the current model of service delivery in preschools. DOE is currently the lead state agency on addressing recommendations being made through the Early Childhood Special Education System evaluation and the Education and Cultural Affairs Committee. However, MaineCare staff have also been monitoring the early childhood discussion occurring in the Education and Cultural Affairs Committee and plan to review the recommendations and incorporate necessary changes to support the early childhood system into the new section of MaineCare policy. In undertaking this work, the department is committed to listening to stakeholders. As we prepare to adopt our school health services policy, MaineCare will work closely with DOE to ensure that the needs of students will be met while ensuring compliance with CMS requirements and limitations. Stakeholders listed specifically in this bill have been reviewing the early childhood system and are also collaborating with DOE in this process. The department anticipates that its new rule will take effect in July of 2022, which will allow for stakeholder engagement regarding key considerations to be included, followed by a robust public comment process. The department is concerned about the bill's change in designation of rulemaking for services provided in schools from routine technical to major substantive. Currently, services allowable in schools for youth from birth to age 5 span multiple sections of MaineCare policy, including occupational therapy, physical therapy, speech therapy, nursing services, behavioral health services, and rehabilitative and community support services for children with functional impairments and cognitive limitations. Changing each of these MaineCare rules to major substantive would have the unintended consequence of creating additional burden for department staff and the legislature, including for rule updates that are not education related. This change could delay the availability of critical health-related services to children and to other MaineCare members who rely on services under these sections of policy, and make budgetary planning for school districts less certain as they await finality of the rules. Even for the changes that are related to education, delaying the rule for legislative review could have a negative impact on districts' ability to plan and budget for necessary services for students in the upcoming year. I will be happy to answer any questions you have and will plan to attend the work session.
Thank you, Director Probert. Are there any questions? Yes, Senator Moore.
Yes, thank you, Senator Claxton. I guess what I'm trying to understand when you mentioned in your testimony that the department anticipates that this new rule will take effect, is this new rule being considered a major substantive rule?
No, it is not. The rule is not currently considered major substantive, and so the department's current plans involve the routine technical rulemaking process.
Okay, gotcha. Thank you.
Are there any other questions? I don't see any. Thank you for being here, Director Probert, and we'll see you at the work session. And the language of that bill has been clarified some, and we'll be interested to see what that shows. Also, I don't see anybody else testifying against, but we do have somebody who wants to testify neither for nor against. So we'll welcome back Ms. Cronin.
Hello again. Let me just get my testimony up. There we go. Senator Claxton, Representative Meyer, and distinguished members of the Joint Committee on Health and Human Services. My name is Nancy Cronin, and I am the Executive Director of the Maine Developmental Disabilities Council. In the spring of 2019, the 129th legislature passed a section in the, I'm sorry, my dog is of course wanting me to play with my ball, with his ball right now. Legislature passed a part of the budget which authorized funding for an independent review of the Maine's early education system. That's the PCG report that you've already heard about. An advisory committee was named to assist the executive director's office of the Maine's legislature in the provision of the study and provide advice to the education committee, recommending our proposed changes to improve the early intervention system. I acted as the chair of that advisory committee. In light of this bill, it is critical that this committee have a good understanding of the changing landscape of the early childhood system and work closely with the education committee. Without that coordination, I fear that the system will get even more muddled. The advisory committee read through many reports and cost studies and ultimately recommended 4 pathways for the education committee to consider. The reason for those recommendations would be a report in and of itself, and I'll happily elaborate if you have questions. But I wanted to let you know what those 4 recommendations were. We recommended that the education committee, 1, submit legislation to move the 0 to 2-year-olds education system away from CDS and to the Department of Education. 2, there's been a lot of discussion and PCG recommended that the 3 to 5-year-old preschool system be moved to SAUs. We didn't necessarily completely agree with that nor disagree. There's too much that has to be talked about still. However, we did recommend that the education committee make a decision as soon as possible which direction they want to go on so that we could get the work done. And we provided some recommendations on how to get that work done. 3, write a letter to the Department of Education requesting that they identify children earlier and implement some of PCG's recommendations. And here's the one that I really want you guys to hear. 4, work with the Health and Human Services Committee to create a centralized billing system so that the education IDEA funds can seamlessly be braided with Medicaid funds and schools and providers can correctly receive reimbursement.
30 seconds, Ms. Cronin.
Okay, this is a critical recommendation. In that early intervention is both part of IDEA and Medicaid's EPSDT requirement. This recommendation spans both departments and the oversight of both committees. Currently, because billing is fragmented, schools and providers often do not access 1 or 2 funding sources, leaving millions of federal dollars on the table and overburdening state coffers and property owners' tax burdens. It also creates an uncoordinated, less efficient early intervention system. All right, thank you. I will stop here and ask if you have any questions. I would be very happy to talk more about it. I will say one last thing, which is if there was a centralized billing unit, DAFS already conducts the Health and Human Services contract billing unit. They could easily do this as well. Thank you.
Thank you for your testimony. And yours is about the 3rd or 4th dog who's joined the hearings in the course of things so far. Are there any questions for Ms. Cronin? Yes, could you clarify the second one for me? The recommendation was to move the 3 to 5-year-old work from CDS to
Absolutely.
where?
There's been multiple bills recently to move the 3 to 5 from CDS to school systems, to local school districts. Okay. The implications of this will be great, but we are the only state in the nation that doesn't have their local school district providing this service. So it is simply to merge all of 3 to 21 IDEA so that school districts do the entire thing and not CDS.
And I remember some very vocal pushback from the school systems because it wasn't tied to money.
Yes, and towns.
All right, so I do remember that. Okay. All right, are there any other questions from Ms. Cronin? I don't see any. Thank you for being here. Are there any questions? I don't see anybody else who's neither for nor against. And we can then go, yes, Representative Meyer.
It looks like Ms. Busquet has returned.
Yes, thank you.
Oh, there you are. Okay, welcome back.
I apologize. I'm having some technical difficulty here. Everyone, my name is Rachel Busquet, Senator Claxton, Representative Meyer, members of the Joint Standing Committee. I appreciate you to allow me to provide this testimony in support of LD 854. Like I said, I'm Rachel Busquet. I'm the Director for Residential Education Services for Kids Peace. Kids Peace is a profit statewide provider of a wide range of community-based mental health, education, and child welfare services. Most relevant to this bill, we provide behavioral health services in our special purpose private schools located in Ellsworth, Millinocket, and Old Town. In addition to K-12 classrooms, we have pre-K developmental preschool programs in each of these locations. A change in main care rules for medically necessary school-based services and developmental preschools without corresponding changes in educational rules and funding has the potential to pull the rug out from some of Maine's most vulnerable children. This is the situation that we were in last year. I came before the committee last March on this issue, and I'm thankful for Representative Meyer and members of this committee who listened to the parents and providers and helped move this bill, similar provisions, out of the committee with bipartisan support. Kids Peace in principle supportive of the idea of consolidating Maine rules currently found in section 65 and 28 of the Maine Care Manual into a single section. The devil, however, is learned truly in the detail. The formerly proposed section 106 rule was a disastrous if unintended consequence for 3 to 5-year-old children who are in need of service specifically designed program of learning readiness. For example, in our Old Town program, we are serving over 25 families whose children have special needs, with 10 plus current children on the wait list. The rule previously proposed to cut up to 50% of services and 90% of the kids in this program. While I'm thankful that the rule is withdrawn for now, the fact makes the point that this rule is, as reconsidered, should be major and substantive and require broad stakeholder engagement. I expect no one in this room disputes the importance of early intervention for children with disabilities. This is simply an established fact. Early intervention is critical for later education attainment and social success. There is no doubt that this existing funding and regulatory requirements are coming in exactly from 2 state departments are complex and often inconsistently applied. And this is exactly the reason why we should make this rule for stakeholders groups to be formed as the bill supports. I'd like to end on a personal note. In addition to be the director of overseeing these services, I'm a therapeutic foster parent with a 5-year-old developmental pre-K program. I know from the experience just exactly how important these services are to him and those who love him. We should be able to help shape these rule changes to this service before we implement the passing of LD 854. Thank you, and I'm happy to take any questions.
Thank you for being here and persisting and trying to get here. I see that you have written testimony, and you were breaking up just a little bit at the end, so any gaps we can fill in from that. Are there any questions for Ms. Busquet?
My stomach is growling.
I don't see any questions. So thank you for your persistence and thank you for your testimony. Now we can go, I think, as the last person who wanted to testify, to our analyst and see if there's any questions or a direction we would like to share with Anna. Thank you for bringing a very simple bill forward, Representative Meyer. Yes, Representative Perry.
Yeah, I think I need to understand a little bit more about the bill that went before education. That is supposed to do some coordination with the HHS and stuff. I don't know if that's something Anna could bring forward to give us a little bit of understanding of what's in place and what we're looking to change.
Are there other questions? I think I might be looking to review some of the testimony from last year to understand what was flagged, because I remember that as one of the first deluges of emails that I got when we got to the 106 conversation. Any other question? Anything else for Anna? I don't see anything then, so we'll wrap up consideration of Representative Lemelin.
Thank you, Senator Claxton. My question is not for Anna. It's if I could ask Representative Meyer a question about her bill real quick, because I'm hugely in favor, of course, of preschoolers getting all of this. But they're mentioning IEPs. And if we're talking about preschoolers, what preschool organizations have IEPs?
So maybe that's something that we
can. Is there any?
Does anybody know? I think probably you're asking a group that probably isn't too well informed about that. Representative Craven, did you have an answer for that?
Yes, thank you, Mr. Chair. All of the special purpose schools that provide that provide education and care for those preschool children has to have an IEP, as if they were in public, as if they were getting any other kinds of services for children with developmental disabilities.
And one last thing then for Anna, could we get a list of these preschools that we're talking about? I didn't know such a thing existed, actually. Most preschools are, except maybe in Portland or some of the bigger cities, most preschools are rather small, and I don't see how they could provide these services except for externally. And does this bill cover that, I guess would be my question.
So we might benefit from some examples of some of those preschools and how those services are provided, because I know a lot of that isn't standalone, it's contracted. And the kids do some shuttling is what I understand. So if we can get some clarity from the advocates about that issue, that would be helpful. Thank you for the question, Representative Lemelin. Are there any others? Not hearing any and not seeing anybody else. Representative Craven.
Thank you, Mr. Chair. I'd be interested in having some more information about Nancy Cronin's testimony and the early intervention program that she worked on.
Okay. All right. So I don't see any other comments related to LD 854. I turn to the analyst to see if there's anything else we need to do before we entertain a motion to adjourn for lunch.
So moved.
And everybody who's ready for an hour-long break, amazing. Thank you all. We'll see you at 2 o'clock.
Oh,
That was a luxury of a nice long lunch for the HHS committee.
I agree. We deserved it after that morning.
Somebody messed up the schedule and we got a lunch. Cheers, Margaret.
Cheers. Oh, you went to Dunkin' Donuts?
I did.
I don't leave the house, although I had lunch.
Well, it was my first chance to see Representative Bickford in a very long time. He was coming out as I was going in.
How's he doing?
He seemed to be bright-eyed and bushy-tailed.
That's good.
He's using hand controls for his vehicle.
Technology today.
Yeah, it's amazing. No, and I didn't feel like I was at risk of being run over. So no, he looked to be doing well. So the chair is yours. Is that correct?
That is correct.
Senator Meyer?
Thank you. Yes. And you saw the order?
No, but I'm going to defer to the chair.
Okay. So for anyone listening, because we are still recording, it's 1009-972 followed by 1080.
So I'm number 2 then.
You are.
I'm off, so it's not me. What?
We'll give it just another minute to make it to 2, and there we are. Everybody ready? Yes. So, welcome to the afternoon session of the Joint Standing Committee on Health and Human Services. We're assembled around our virtual horseshoe and are live streamed on the HHS channel of the Maine State Legislature's YouTube channel. You can watch us on replay if you miss us this afternoon. We will be holding public hearings on LDs in the following order: 1009, 972, and 1080. For those testifying, we would ask that in order to help our clerk manage the attendee list, you exit the webinar once you've finished your testimony and answered any questions from the committee, and watch the rest of the hearing live on YouTube. We take testimony in the following order: sponsor, any co-sponsors or other legislators, those providing testimony in favor of the bill, those providing testimony against, and then finally, any neither for nor against, but with additional information for the committee. We do run a 3-minute clock on testimony, and you will receive a prompt when you have 30 seconds left, asking you to kindly bring your testimony to a close. Public hearings are just that, for the public. The process of hearing testimony certainly engenders and encourages probing questions, and the committee is asked to use the raised hand function in order to ask those bill-related questions. I'm not sure we need to go around the virtual horseshoe to do introductions, and I think we can probably get right into our public hearings. So I will open the public hearing on LD 1009 and welcome Representative Madigan to present her testimony.
Thank you, Madam Chair. Good afternoon, Senator Claxton, Representative Meyer, and fellow members of the Health and Human Services Committee. I'm Representative Colleen Madigan, and I represent part of Oakland and part of Waterville. I'm here today to introduce LD 1009, resolved to create a healthcare ombudsman position to serve in Maine's county jails. This bill comes out of discussions I have had with advocates and consumers of mental health services. Like several of you, I have been on this committee for a number of years. I can't tell you how many times I and we have heard county sheriffs, law enforcement, consumers of mental health services, advocates, etc., say that our county jails have become one of the largest providers of mental health services. They don't say this because that's a good thing. I have the utmost sympathy for our county jails, who are often tasked with doing a job they were not designed to do. I also have a lot of empathy for those suffering with mental health issues who come to the attention of law enforcement and end up incarcerated in our county jails. You see, I have spent many years working in the behavioral health field. I've listened to too many people who have struggled with their perceptions and traumas that led them to behaviors that in turn led to problems with the law. Sometimes in working with people under these circumstances, it takes a long time to understand what happened, what led them to committing an action that is against the law. I am grateful for the training and experience that has led me to develop those skills. In discussing what to do about this problem with others, we identified that medical problems can often exacerbate or look like psychiatric problems. We also recognize that county jail staff are often tasked with the impossible. They work in an entirely different system than behavioral health and are not trained in that field. I also want to be clear. I recognize that county jails are doing the best to cross-train their staff. Working with advocates and consumers, we came up with an amendment to replace the original bill, which is attached at the end of this testimony. This amendment creates a work group made up of individuals from across these different systems to develop a plan, including exploring funding for solutions to address this problem. I think there are models out there that this group can best explore. Solutions work best when everyone buys into them. I also do not believe that the solution to the problem of our county jails being de facto providers of mental health services is entirely the job of this work group to solve. The plain truth is that a robust, effective, and adequately funded system of mental health services will prevent many people from ending up in jail in the first place. And that would be the much preferred outcome. It would be better for mental health consumers and for county jail staff. We would do well, all of us, to keep this in mind. Thank you very much. I would be glad to answer any questions, and I look forward to working with you on this bill.
Thank you, Representative Maddock. And questions from the committee for the bill sponsor? Seeing none. In the queue, we have April Kerr. Hopefully it's Kerr and not Carr, and I apologize in advance for mispronouncing.
That's okay. It's April Kerr, actually. Okay, this is my first time doing this, so I just want to say good afternoon to you all, Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee on Health and Human Services. My name is April Kerr, and I live in Farmington, Maine, and I'm here today in support of LD 1009 with the proposed amendment. As I have spent the past few years volunteering to be an advocate for consumers of mental health services with the Consumer Counsel System of Maine, I have seen more and more of how my fellow peers suffer. Many times it is due to not having the access to knowledgeable individuals who can assist them in seeking out the services that they need. I've learned much about the needs of people that are in the county jails and how many times these needs end up being not addressed for various reasons. In some cases, the results end up contributing to physical and mental health. Oh, sorry, my screen jumped. Mental health complications that are not only costly, but in some cases, the end results are death. This is not acceptable way of correcting a wrong done by anyone. We need to come together and do something to create a much needed change. I know that there are people in jails who are working towards helping individuals, but their plates are full, and many times the work they end up doing to help those who end up in the jails are not their area of expertise, pardon me. I have heard the sheriff of one county testify in past legislature that he felt that much of the work he and his officers were doing was mental health work, not the work they were hired to do. Let me leave you with this thought. If you had a toothache, would you go to see a therapist or a psychiatrist? Or if you had a problem seeing, would you go see the local veterinarian? No, you might say. What if that's all you have to work with? You know, we work with what we have, right? What if it was your parent or your child who was crying out in the night because they were so consumed with a depression or thoughts of suicide they just couldn't hold it in? Would you go to them? Would you find them a way to get help? I know I would. I know I would do all that I knew to do and try to find them the help that they needed. So I'm saying, let's come together now and do just that for those who are suffering and don't know where to turn. Please vote in favor of bringing together a group of people who can work towards effectively helping those who are in need. Thank you.
Thank you, Ms. Kerr. Questions from the committee? Seeing none. Thank you for being here today. You did very well on your maiden voyage providing testimony.
Thank you so much.
Sure thing. Up next is Ms. Collins, Jan Collins.
Thank you.
Welcome.
Senator Claxton, Representative Meyer, and honorable members of the Health and Human Services Committee. My name is Jan Collins, and I'm Assistant Director for Maine Prisoner Advocacy Coalition. I'm here to speak in support of LD 1009, resolved to create a healthcare ombudsman position to serve in Maine's county jails. I believe it is best to have those with direct experience speak on the issues. Maine Prisoner Advocacy Coalition regularly receives requests for assistance from family and friends distressed at the treatment of their loved ones in Maine's county jails. Included in my testimony are 4 of those letters. I will skim over 2 of them and then make my concluding remarks. I was referred to you because my 21-year-old son has been arrested and is in the county jail in Maine. He has a severe mental disability and has attempted suicide since in custody at the facility. He is and has been on suicide watch since he got there. I have requested appropriate medical expert evaluation and possible transfer to a hospital where he can get adequate treatment. The jail has refused to listen to me, stating that he is stable. The jail will not allow anyone to visually see him, not even his lawyer. His life is in jeopardy in that facility. His mental suffering is being ignored. I am begging for your assistance. Please don't let my son die there. Number 2, I'm emailing on behalf of my friend. She needs help with her incarcerated son, who is not receiving his bipolar and schizophrenia medication. He is currently being held at the county jail, and she has called there many times, also called his lawyer and many other persons in our area for help, and either they won't return her phone call or state that they can't help her. Her son has informed her he plans on committing suicide on or by his birthday, which is in a week, and he is not in his right state of mind. And there are many more of these. Unlike other facilities such as schools, hospitals, and nursing homes, the public does not have access to jails and prisons. It is a closed system. Only people who work in the system evaluate the system. As a result, there are no checks and balances, and there is no one whose responsibility it is to ensure that the prisoner's rights and healthcare are protected. It is my hope that this bill will rectify that lack of access and outside oversight, ensuring the protection and care of those in state custody.
30 seconds, Ms. Collins.
I support a working group to strengthen its provisions. Thank you for your consideration. I hope you will support this bill.
Thank you, Ms. Collins. Questions from the committee for Ms. Collins? Yes, Representative Craven.
Thank you, Madam Chair. Thank you, Jen. I don't understand why somebody's lawyer can't see them, or a family member for that matter, but could you speak to that a little?
Thank you, Representative Craven, I'm sorry. That's a great question. And it's a question that I cannot answer because their attorney should be able to see them. I know that during COVID, which this letter was written during COVID, that many facilities were closed to anyone, but it would seem that it should be possible at least to have a video contact with the person. So I can't tell you why that was denied in this case. It certainly was distressing to the person who wrote that letter.
Thank you.
Thank you.
Seeing no other hands up, thank you for being here today, Jan.
Thank you.
Mr. Jeffrey Kerr. Welcome. You'll need to unmute yourself, please.
Good afternoon. Senators Claxton and Baldacci and more in the Joint Standing Committee on Health and Human Services. My name is Jeffrey Kerr, and I stand in favor of this amendment on the bill 1009. I find that we are all people, and people do make mistakes. I cannot think of one person that has not made one. I believe this is a great bill with this amendment, and I really would like to see it go through as amended. 10 years ago, I was in county jail, and having brain surgery, I needed my medicine as it was prescribed to me. So it was a complete shock to me when they brought an armed guard around with the nurse to take me down to the medicine hall where the nurse was, to find out they wanted me to sign a piece of paper and ask for a cheaper Dilantin. Sorry. I was and I said I would do this, but only if my doctor gave me permission to do it. I was denied. My surgery was out of state, was in Massachusetts. So I had my number on my cell phone. I asked for that, and I was denied. I then, therefore, was told to turn around, put my hands behind my back, to be cuffed again. And I went back to my cell. Knowing this, that was really important to do just as a specialist said after having brain surgery. I said, only if, I lost my place, I'm sorry.
It's okay.
I later found out many times that this happens, not my same situation, but pretty much happens every day. And that's why I became a re-entry coach, and I became on the board of visitors for Franklin County. If you have any questions, I sure would like to answer them.
Questions for Mr. Kerr from the committee? Seeing none, thank you for sharing your experience and for the work that you're doing.
Thank you, ma'am.
Next up is Caitlin Morse. Ms. Morse, welcome.
Good afternoon. Thank you. This is my first time appearing before the committee, and I will be also giving testimony on another bill shortly. Good afternoon, Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. I am Caitlin Morse, a resident of Westbrook and the Policy Associate of the Alliance for Addiction and Mental Health Services. I am submitting this testimony on behalf of the Alliance in support of LD 1009, a resolve to create a healthcare ombudsman position to serve in Maine's county jails. The Alliance represents Maine's safety net community-based mental health and substance use treatment agencies. We advocate for sound policies and evidence-based practices that serve to enhance the quality and effectiveness of our behavioral health care system. Access to behavioral health services for the most unstable and vulnerable members of our community is one of the issues we feel most passionately about at the Alliance. Treatment facilities in Maine are insufficient to meet the need. Jails are tense places where mental illness is exacerbated. Nationally, around 80% of prison and jail inmates had either mental health or substance problems. We know this is consistent in Maine, where lack of appropriate access to medication, mental health services, and other healthcare resources make things more difficult. When mentally ill adults in Maine struggle to get appropriate care, they may languish in local jails rather than enter the state's mental health system. Prisoners with mental illness are often transferred from one facility to the other in what has been referred to as the diagnosis game. Jail staff oftentimes even experience their own struggles with mental health. There's a silent epidemic among lockup staff nationally, and more than 19% struggle with post-traumatic stress disorder. The risk of suicide for corrections officers is higher than all other professions combined. This vicious cycle would be alleviated in part through ombudsmen who would be aware of system issues and appropriate living conditions while also understanding and having access to behavioral health care resources. Please support LD 1009 with a not to pass vote.
Thank you, Ms. Morse.
Thank you.
Any questions from the committee? Seeing no hands up, we thank you for being here. Up next, Mark Joyce.
Hello, Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Mark Joyce. I'm an attorney with Disability Rights Maine, Maine's protection and advocacy organization for individuals with disabilities. I'm also one of the class counsel for the High consent decree case, and I'm here in very strong support of this bill and this work group. I think I've been doing this work for many years. We've been to many of the jails, in fact, all the jails. We've been to all of the prisons, and there is a lack of people on the ground in the moment in these facilities who can actually, what happens is you have to have individuals who are there day in and day out, right? And so I think this sort of work group, we support wholeheartedly for the ombudsman, because if you have those individuals on the ground in these places who know not just about mental health, but also about other services. And I think I'll echo some of the other people who testified, is that an individual may have housing issues. They may have issues in terms of their Social Security. They may have treatment issues. They may have physical treatment issues. And so the whole person needs to be treated wherever they may be in the system. And so what happens is that if they are in jail and they don't have access to these services, or more importantly, I think sometimes someone who can link them, because like a person said earlier, the jail staff are not trained as case managers to link people to these services. So we think a work group to sort of focus on this and figure out a solution, we think would be very, very good, and we support it wholeheartedly.
Thank you. Seeing no hands up with questions, we appreciate you being here today. Simone Mallon, welcome.
Hello, Representative Meyer and Senator Claxton and esteemed members of the Health and Human Services Committee. My name is Simone Mallon. I'm the Executive Director of the Consumer Counsel System of Maine. And I'm here today to strongly support LD 1009 as amended. We have worked with Representative Madigan on this issue because, again, as we go out into the community and do forums and find out the issues and concerns that people have living with mental health challenges, issues with jails is right up there at the top of the list of things that people bring to our attention. And so we started working on this bill and we started to learn, we're not jail experts. And so we started to learn more things that might be more helpful in this process. We've also met with the director of the ICM program for the state through Office of Behavioral Health. And there's a lot of work being done on discharge planning, and there's some new initiatives around diversion from jail. But for those that happen to end up in the jail system, it is often not a place where you can get resources. And we learned it's not just healthcare, mental health, or physical health care. It may be family law. It may be an interpreter if you're deaf, or if you speak a different language. Those things often are people are stuck with those, and who do we call? Who will help us? And again, we hear over and over and over again, as Representative Madigan said, county jails talk about being the largest mental health facilities, which we want to change. And for those that do end up there, we feel strongly that either a resource navigator or an ombudsman person that can really help look at this issue more closely and help connect people with the needed resources. We don't want to ask the county sheriffs to add more to their plate. They have more than enough to do. And we also realize we need to look for funding. And so when we started to do the work for this bill, we realized there was a lot more to what we were asking. And so that's why we've gone the route of getting all the experts together and coming forward with some better recommendations and hopefully funding sources that don't put additional burden on state government and county jails.
30 seconds, Simone.
Thank you. You know, because we dream of a day when the sheriffs are not saying that they're the largest mental health facilities in the state of Maine, because we have done a huge disservice to those needing mental health care to have it in jail. So we want to make the system as best possible. So this is our attempt at trying to fix the system in one way. Thank you.
Thank you, Simone. A question from me, prior to receiving the amendment to this bill, what this LD asked for was that the DHHS designate an intensive case manager to serve as the healthcare ombudsman. Do you, when you were working on this, did you see the ICM as the appropriate member of the team to perform that service, to serve in that role?
Honestly, earlier on we did, but understanding that sometimes this needs to be, one, it was so we wouldn't be putting an additional financial burden. So allocating a state position to this role felt like at first the smartest thing to do. And we learned that there needs to be an independent voice that might be that person. And so that's why we have kind of taken that piece of the ICM out. They certainly will be an integral part of the team and an invaluable resource, but their roles are different than what we're seeing now in the county jails. And they're playing a very important role and would be part of the team. But I think having an outside independent entity is what we've been hearing from, as we've talked to other advocates, including Jan and others, that having it independent is a really important feature. So that's why we've pulled the ICM piece out.
Yeah, understood. Thank you. Any other questions for Simone Mallon? Seeing none, appreciate your being here today.
Thank you.
Up next, I see no one is providing testimony opposing this bill. So we've got testimony neither for nor against from York County Sheriff Bill King. Sheriff King, welcome.
Oh, thank you very much. And thank you for inviting me here, for being here. Senator Claxton, Representative Meyer, and esteemed members of the Joint Committee on Judiciary. My name is Bill King, and I'm the Sheriff of York County, as well as the first Vice President of the Maine Sheriff's Association. Maine sheriffs discussed this amended language generously provided by the sponsor, Representative Madigan, and we collectively decided that our position is neither for nor against. As you may know, there are 14 county jails and 1 regional jail in the state of Maine. All jails have some level of healthcare providers, as residents of correctional facilities are the only class of people that are required by law to have medical care. All facilities have 24/7 medical staff available or have arrangements with nearby providers to seek medical attention quickly for a resident. This bill creates a 17-member working group to design jail resource navigators for Maine's jails. Justification for this new position is explained in the summary that indicates the working group will be tasked to design county jail navigator services that will support all county jails in Maine with needed resources or services for those incarcerated. The summary continues. Currently, many jail administrators are unable to adequately address this due to lack of personnel dedicated to meet these needs. Maine sheriffs are not certain which jail administrators believe their jails are not adequately addressing residents' health care. In York, we have a professional correctional health care provider and a professional monitor to ensure that medical and mental health services are delivered with the highest standards. Two other jails, Cumberland and Somerset, are certified by the American Correctional Association for their healthcare services. In York, we don't have that ACA certification, but our healthcare provider assures me that she abides by ACA standards. All other jails are inspected with biennium inspections by the Maine Department of Corrections. And part of that inspection is a review of medical and mental health services. To date, each and every jail has consistently earned ratings in the highest scoring bracket available. Maine sheriffs are not opposed to ensuring incarcerated residents obtain adequate mental and physical health care, but the insertion of an ombudsman could complicate the process. At present, residents may complain to the MDOC about their healthcare treatment, and MDOC will initially ask us for an explanation. And if that doesn't satisfy them, they will commence an investigation. Having a third individual involved to solicit complaints to ensure residents get adequate health care seems cumbersome.
30 seconds, Sheriff King.
Pardon me?
30 seconds.
Okay. This would become especially problematic if the ombudsman is not a trained healthcare provider themselves. I envision a doctor's time being expended answering an ombudsman's inquiry about the treatment plan for a resident, time that could potentially be better spent conducting proactive examinations. We believe the ombudsman could be most helpful filling a gap that exists when an individual is released. The ombudsman could be tasked with researching providers in the area where an individual is released and confirming that a continuation of care or that treatment, whether physical or mental, continues. This is a vital, recognized gap, and the ombudsman could also coordinate additional community supports for an individual with a substance use disorder that is being released. Maine sheriffs applaud the forward thinking of the sponsors of this bill, but seek additional clarity surrounding the role of the ombudsman during a resident's incarceration. Until then, the Maine sheriffs will assume a neutral position on the legislation, and we look forward to being a participatory member of this work. And we appreciate the opportunity to present to this committee, and I'd be happy to answer any questions if you have any.
Thank you, Sheriff King. Questions for Bill King? Yes, Representative Craven.
Thank you, Madam Chair. Thank you, Sheriff. So I'm guessing that you contract with a healthcare provider to come into the jail to provide the services, and wonder how much jurisdiction you personally have. We just had somebody testify that he was asked to take a generic drug instead of the one that his physician had prescribed for him, and didn't want to deviate from the prescribed medication. And I just wonder, that seems dangerous if you're just done with brain surgery. So I just wonder if you could speak to that a little bit.
Well, I really can't speak to that particular circumstance that individual testified to, but I mean, I'm not going to put myself in a position to second guess a doctor that is recognized and certified and has all the appropriate licenses. Again, I mean, there's a lot of avenues for a resident to make a complaint, and I don't know if taking a generic drug would rise to the level of MDOC, finding us at fault. But as far as I really can't speak to whether a doctor should prescribe a generic drug over a different one.
Any other questions for Sheriff King? Seeing no hands up, thank you for being here today, Bill.
Thank you very much. Appreciate it.
Finally, testifying neither for nor against is the department's Molly Bogart. Welcome, Molly.
Good afternoon. I'm Molly Bogart, Director of Government Relations for DHHS. I just want to let you know that there's a letter from Dr. Pollard that has been submitted that is sharing some of our concerns about the original draft of this bill that directed us to use intensive case managers to fill this position. We would have some concerns if that was the directive. We appreciate the sponsor's amendment and recognize that that may no longer be a concern, but wanted to submit that just for the record. I'm happy to answer any questions about that or bring more information to the work session, but just wanted to be clear that those concerns were about the original bill, not necessarily the amendment.
Thank you, Molly. Questions for Molly? Seeing none. Looks like we have heard all the testimony on this LD. I'll turn to the committee and ask for any requests for additional information from our analyst. Seeing none, we will close the public hearing on 10:09 and open the public hearing on LD 97. Oh, I'm sorry. Wow, there's all kinds of hands up I'm ignoring. I'm not sure who was first, but I'm going to go with Ann Perry, Representative Perry.
Okay, thank you. My hope is the department will be here for work session as they evaluate the amendment. I would like to get a sense of what their position would be on this.
Representative Craven.
Thank you, Madam Chair. I'd like to know if there's a model in any other state that has an ombudsperson or even a group that would similar to what Representative Madigan has suggested. Thanks.
And I guess I would piggyback on Representative Craven's whether or not there are any models for a navigator in this regard, with regard to the jails. Now, I'm not missing anyone else, so now we actually will move on to LD 972, an act to establish the Rare Disease Advisory Council, presented to us by its sponsor, Representative Margaret Craven. Welcome.
Thank you, Madam Chair. Good afternoon, Senator Claxton, Representative Mayer, and fabulous members of the Health and Human Services Committee. My name is Margaret Craven, and I represent House District 59, which is part of Lewiston. I'm pleased to be in front of you this afternoon introducing LD 972, an act to establish the Rare Disease Advisory Council. This bill would establish a Rare Disease Advisory Council in Maine, following the work of 16 other states, including New Hampshire, Massachusetts, Connecticut, New York, Pennsylvania, Ohio, West Virginia, North Carolina, Alabama, Texas, Tennessee, Kentucky, Illinois, Missouri, Minnesota, Utah, Nevada, and Texas and Wisconsin and Michigan and Florida are working on the process. And sorry to say all of those states, but I don't want Maine to be left out. So according to the National Organization of Rare Disease, there are 7,000 known rare diseases. Access to accurate information and resources for those individuals with these diseases and their families can be limited. As policymakers, our understanding of their needs and any number of obstacles they face is also limited. A Rare Disease Advisory Council in Maine would make it easier for state government to address the barriers and prevent Mainers living with rare diseases from receiving the proper care and treatment for their conditions. At the end of the day, the proposal is about improving the quality of life for fellow Mainers. I think it's worth mentioning that the conversations I had with representatives from biotech and pharmaceutical companies have shown they're also supportive of this measure and see it as an important step forward. While they're not here today, this afternoon, the committee can expect their testimony in advance of the work session. Thank you for your time and consideration, and I'm happy to answer any questions, but I'm sure you get more accurate answers from people that are coming after me. Thank you.
Thank you, Representative Craven. Questions from the committee? Seeing none, we'll move on to first testimony in support of this bill. Allison Hills, welcome.
Thank you. Good afternoon, Senator Claxton, Representative Meyer, and honorable members of the committee. I submit my testimony today in support of LD 972, an act to establish the Rare Disease Advisory Council. My name is Allison Hills, and I'm currently a graduate student at the University of Maine in Orono in the Master's of Social Work program. Based on my work experience in both professional and educational capacities, I see the importance of getting resources out to the many rural communities in our state. Many Mainers struggle with getting a rare disease diagnosis and struggle with finding adequate resources within the state to help address the biological, social, psychological, and economic areas that are affected by a rare disease diagnosis. Establishing a Rare Disease Advisory Council is an important and necessary first step in addressing the unmet needs of Maine residents who face rare diseases. I urge the Health and Human Services Committee as well to have the proposed Council of Medical Professionals to make great efforts to include mental health professionals along with those affected by rare diseases and their families and/or caregivers. I strongly support the passage of this bill. I appreciate your time for letting me speak to the committee today, and I will answer any questions to the best of my abilities. Thank you.
Thank you. Questions for Ms. Hills? Seeing none, we'll move on to Anissa Reed. Welcome.
Thank you. Good afternoon, Chairman Claxton, Chairwoman Meyer, and members of the Joint Health and Human Services Committee. My name is Anissa Reed, and I am the State Policy Manager for the Eastern Region with the National Organization for Rare Disorders. Thank you for the opportunity to testify before your committee in support of creating a Rare Disease Advisory Council in Maine. Unfortunately, rare disease patients face unique challenges every day. A Rare Disease Advisory Council in Maine could provide a forum for stakeholders across the state to analyze the needs of the rare disease community and make recommendations on how to improve public policy. We're grateful to Representative Craven for her introduction of LD 972. LD 972 will accomplish critical goals of an RDAC, including increasing awareness of the burden caused by rare diseases and requiring the issuance of an annual report that includes a summary of the activities of the council and any legislative or policy recommendations of the council. However, we would recommend the following modifications to the legislation. First would be to increase the diversity of membership within the council. We recommend adding a representative from an academic research institution, a representative from Maine Care, a representative from the Bureau of Insurance, a geneticist practicing in the state, a representative from biopharma, and a representative of a health plan operating in the state. Including broad participation from the different healthcare sectors operating in Maine will help the RDAC serve as an educational resource to all stakeholders about the ways rare disease patients interact with our healthcare system. Second, NORD recommends removing some of the duties that focus on state-based research to focus on other duties that can impact the Maine rare disease community at large. Some state RDACs that emphasize research up front have struggled to get comprehensive data, which resulted in delays in the development and delivery of recommendations that could help rare disease patients. Additionally, data around incidence, causes, and economic burden of rare diseases can already be found through the National Institute of Health and other rare or disease-specific research and advocacy organizations, including NORD. Therefore, we'd encourage the legislature to instead require the council to convene public hearings and solicit comments from the general public to help set the course for issues the RDAC can work on. And lastly, we would also recommend the council be tasked with making recommendations on key public policy issues and distributing educational resources for patients and healthcare providers. This can be accomplished by publishing a list of publicly accessible resources relating to the rare diseases in Maine on the council's website. Additionally, we'd recommend the council be clearly tasked with making recommendations to state agencies and insurers on issues that impact Maine's rare disease community. With these modifications, thank you. With these modifications, the RDAC established through LD 972 will provide decision makers in Maine with a forum to better understand and meet the needs of their constituents. Once again, thank you for adding LD 972 to the Joint Health and Human Services Committee's agenda. We urge its swift passage as amended to reflect NORD's suggested modifications. Lastly, just to share, a few weeks ago, Virginia signed an RDAC into law as well. So it is now, we're excited to say 17 states. Thank you.
Thank you, Ms. Reed. Questions from the committee? Seeing none. Did the the legislation that was just passed in Virginia, did it mirror the recommendations you just laid out here in your testimony?
Yes, it did.
Senator Claxton.
Thank you, Madam Chair. Are there different models for these councils or these advisory committees in terms of standalone versus embedded in a state government department? And is there some way to extrapolate from that which are more likely to succeed?
Yeah, that's a great question. We do want different states to look unique to their disease-specific needs of the rare disease community. Typically, we have found RDACs to be most successful when they are a standalone council to ensure that they're inclusive of all at least 7,000 rare diseases and focus on issues that everyone in that population typically faces.
Can I follow up question?
Yeah.
Yes, we recently heard a bill to provide funding for one of the rare conditions. And I'd be looking for some guidance about how people advocate for allocating limited dollars to these rare diseases. And if there's any guidance that your group could provide, that will be helpful.
Yeah, absolutely. I can follow up with that information. And what's unique about the council is we do try our best to be as inclusive as possible on public policy issues that impact the entire rare disease community, but I'll definitely follow up on your question.
Thank you. Thank you.
Thank you for being here today.
Thank you.
Up next is Kevin Dickinson. Welcome, Mr. Dickinson.
Thank you. Good afternoon, Chairman Claxton, Chairwoman Meyer, and members of the Joint Health and Human Services Committee. My name is Kevin Dickinson. I am the Maine Rare Action Network Volunteer State Ambassador for the National Organization for Rare Disorders. Thank you for the opportunity today to testify before your committee in support of creating a rare disease advisory council here in Maine. In 2014, I was blessed with the arrival of my youngest daughter, Kenzie. At first, everything seemed normal, but as the months went on, it became evident that Kenzie was falling behind and not meeting her appropriate developmental milestones. First, we were told that she's not out of the ordinary, she just may need some more time to develop, until she was eventually referred to a neurologist who started genetic testing. Everything was getting rolled out and checked off the list, until finally, this neurologist ordered an MRI reluctantly. She immediately pulled us aside after seeing the imaging. The doctor told us that she had good news, that Kenzie did not have cancer, and the bad news, that she had a mitochondrial disease known as Leigh's disease, and she will not make it out of her single years most likely. This was our first misdiagnosis. Our story is not that unique amongst the rare disease world. Many families and patients go through numerous misdiagnoses and testing before finding their answer. Our family started doing our own research and found a team in Boston that takes care of Kenzie to this day. They found that she has an ultra-rare genetic disorder of the VPS 13D gene. So it is an unnamed disorder, initially one of 6 known cases in the world, which today Kenzie is one of 20 known cases. Insurance will cover most claims, but this disorder is unnamed and does not exist under any claim codes as a diagnosis. This makes covering some equipment and medications extremely difficult. A rare disease advisory council here in Maine is so important to help remove barriers that exist not only getting treatment, therapies, medications, and most importantly, help for those dealing with rare disease, but also identifying and diagnosing those with rare disease. This can be extremely challenging in our state, from the northern rural areas of Aroostook County, where I was born and raised, down a rugged coastline and forested interior, to the more populous southern counties where I live today with my family. Today, Kenzie is 6 years old, and still we encounter a lot of barriers in her care. And RDAC in Maine will be fundamental in starting the process of change for the better, to recognize that the rare disease community exists and tackle the barriers so many of us have faced. As Maine's volunteer state ambassador, I have been able to help families firsthand to welcome and ease them into the rare disease world. And RDAC will bring the needs of the rare disease community in Maine front and center to help address and overcome the barriers we face as a community. Thank you for your.
Thank you, Mr. Dickinson. Questions from the committee? Seeing no hands up, thank you for sharing Kenzie's story with us.
Thank you.
I see no one else in the queue to provide testimony, so I would ask the committee if you have any requests for additional info from Aaron. Yes, Senator.
Thank you. I'd be curious to know if this idea has been floated in legislation before and why it doesn't exist already, frankly. So I wonder if we can have the law library do some homework for us. Thank you.
Anyone else? No hands up, so we'll close the public hearing and we will open our final public hearing for this afternoon. And that is LD 1080, resolve directing DHHS to update the rights of recipients of mental health services, presented to us by its sponsor, Representative Holly Stover. Welcome. You are, Holly, you'll need to unmute.
Okay, thank you. Good afternoon, Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. I appreciate the opportunity to appear before you today to present LD 1080, a resolve directing the Department of Health and Human Services to update the rights of recipients of mental health services. This resolve requests that the Department of Health and Human Services update the rights of recipients of mental health services pursuant to the Maine Revised Statutes, Title 34B, Section 3003 and 15002. The revisions must align with the contractual agreements with service providers, current federal and state confidentiality laws, and best practice standards for the delivery of clinically appropriate assessment and treatment models for people with mental illness. The rights need to be updated to reflect the language, practice changes, institutes, and organization name changes. These rules were initially promulgated in October of 1984 as part of the consent decree and last amended in January of 1995. I think we all can reflect on the fact that a lot has changed for us since 1995. There have also been substantial changes in mental health treatment and services since that time, and this guiding document needs to reflect the current systems of care. One of the substantive practice changes has been our understanding of the impact of adverse childhood experiences, or ACEs, and subsequent traumas for people who are living with mental illnesses. This resolve requests that the department update the rights of recipients to include trauma-informed principles of care as developed by the U.S. Department of Health and Human Services, SAMHSA. The rights of recipients of mental health services must include the current names of departments, institutions, and offices within now DHHS. There are named entities that have changed and others no longer exist, like the Office of Advocacy, which is in the rights in the current document, but it just doesn't exist anymore. It is critical that these amendments accurately reflect the names and services that are current. The rights also should include protections we currently have under law, including recognition of the protection of one's sexual orientation, gender identity, or expression. There have been changes to that law that must be incorporated and recognized through an update to the rights of recipients to accurately reflect the current standards of mental health services and treatment for individuals in the state of Maine. In closing, this resolve respectfully requests that the department update the rights of recipients of mental health services for persons living with mental illness on or by January 1st, 2022. Thank you, and I'll take your questions.
Thank you, Representative Stover. Questions for the bill's sponsor? Seeing none, we will move to welcome Caitlin Morse. Welcome back.
Good afternoon, Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. I am Caitlin Morse, a resident of Westbrook and the Policy Associate of the Alliance for Addiction and Mental Health Services. I am here to submit this testimony on behalf of the Alliance in support of LD 1080, resolve directing the Department of Health and Human Services to update the rights and recipients of mental health services. Our alliance is made up of 35 members and represents the majority of Maine's safety net community-based mental health and substance use treatment providers. Our members offer services in every county in Maine. They represent the full continuum of behavioral health, mental health, alcohol, and other drug use and addiction treatment services. We also represent peer recovery support services. This bill will impact the direct care work our members do for patients and the way our members serve patients in Maine. The Alliance advocates for implementation of sound policies and evidence-based practices that serve to enhance the quality and effectiveness of our behavioral healthcare systems. As you've heard, we believe that LD 1080 is a good start in revising policies that, as you've heard, have gone without update since 1995. It is also important that the department engage a stakeholder group in revising these best practice treatment models for future rulemaking. As a part of this process, there should be representatives from Maine behavioral health organizations involved. And with this caveat, we ask that you please support LD 1080 with an ought to pass vote. Thank you, and I am happy to get you additional information if needed.
Thank you. Questions for Ms. Morse? Seeing none. We will move to Katie Fulham Harris. Ms. Harris.
Good afternoon, Senator Claxton, Representative Meyer, members of the committee. I am Katie Fulham Harris from Maine Health, and I appreciate the opportunity to testify in strong support of this legislation and thank Representative Stover for submitting it. So why do these rules need to be updated? You've heard a little bit that some aspects of the rule are obsolete, such as the grievance process that relies on a director of the Division of Mental Health and an Office of Advocacy, neither of which exists today. And the rule's definition of patient attributes, which Representative Stover mentioned as well. And there are some more important and treatment related aspects of the rule that are really problematic at this point that we also would like to see changed. The rights of recipients specifically requires that patients provide written informed consent before receiving treatment, including medications. And this adds to the stigma associated with mental illness, as the only other type of treatment that specifically requires written informed consent for medication is some forms of advanced chemotherapy. This provision is really difficult, particularly for patients who have paranoia and who are willing to take medication and verbally consent to it, but are not willing to sign a document due to the symptoms of their disease. So that's one antiquated component. Another troubling requirement is the right of patients to pick and choose individual services, even when those services are not supported by the standard of care. This can really lead our clinical teams to puts them in a catch-22, as they're required by the contract with the department to provide the service, yet the individual service in isolation is unlikely to benefit the patient. So I think that can result in significant challenges. For example, a patient who has multiple unsuccessful antidepressant trials for severe depression is unlikely to respond to yet another medicine alone, but may respond to psychotherapy or a combination of medicine and psychotherapy. If the patient chooses treatment that is not evidence-based and then has an adverse outcome, the treating provider can actually be held liable for the adverse outcome. So the rights of recipients does not give the provider the option to refuse to treat the patient, but the provider can be held liable. And that's just another example. So as we seek all opportunities to improve the delivery of mental health care in Maine, it's really important that the laws and rules and regulations support current standards of care and reflect the society in which they're being delivered. The rights of recipients really doesn't reflect either at this point, and can actually impede the effective delivery of services to individuals with mental health diagnoses. We are very comfortable with the suggestion that we should have a stakeholder group that comes back together to update the rights of recipients. So would absolutely support that as an amendment to this legislation. And with that, I'd be happy to answer any questions.
Questions for Katie Fulham Harris? Seeing none, appreciate you being here today, Katie.
Thank you.
Lisa Harvey McPherson, welcome.
Good afternoon, Senator Claxton, Representative Meyer, and committee members. My name is Lisa Harvey McPherson, and I'm here to speak in support of this bill. You've had a great overview of the history of why this bill was brought before you. We're dealing with 26-year-old rules. So we are in full support of taking a look and updating the rules. And I do want to emphasize the need for a stakeholder group to engage in collaborative discussion on best practice. For those of us who are in healthcare, discussing best practice and coming to consensus on best practice can be a vibrant discussion. And so we really need to be inclusive, having all of the voices at the table, because that will really make implementation of the rule most effective. And with that, I welcome any questions that you have.
Thank you, Lisa. Questions from Ms. Harvey McPherson? No hands up. That concludes the testimony in support of the bill. Testifying in opposition is Simone Mallon. Simone?
Hello again, Representative Meyer, Senator Claxton, esteemed members of the Health and Human Services Committee. My name is Simone Mallon. I was just with you a few minutes ago, and I'm back today to oppose LD 1080. And never in a million years would I think I would be opposing a bill concerning the rights of recipients, because we've been advocating for a revision of this document for many years. I think my entire time I've been with the council, which is 10. So it is not that the rights of recipients does not need a major overhaul. We're opposing it because we just have a whole new agreement with the consent decree. And I know Mark's up probably after me to talk about it, and you've already heard much about that already. We feel like those things haven't even been put in place yet, and we need to get those pieces settled before we tackle the rights of recipients. I know there's discussion of best practice and those kinds of things, but the rights of recipients is really, it is born out of the consent decree because of tragedies that have happened to the mental health consumer community. So whereas this is the focus that needs to be, not that our allies and partners aren't an important piece of this, but the rights of recipients solely really is about from things that have happened in the years of AMHI and before, and moving forward. And we hope that we could delay this work so the consent decree pieces that are new can be finalized and put into place, and we can then move to fixing the rights of recipients. And because that is something we have been advocating, as I said, for years. So with that, I just would urge you not to pass it so that we can actually do the work when the consent decree pieces are settled. And thank you for your time.
Thank you for being here, Simone. Questions for Ms. Mallon? Seeing none. Mark Joyce, welcome back.
Yes, thank you. Thank you, Representative Meyer and Senator Claxton and the members of the Joint Standing Committee on Health and Human Services. Again, my name is Mark Joyce. I'm a managing attorney of Disability Rights Maine, Maine's protection advocacy organization. Also the council and the AMHI consent decree. And I echo what Simone said earlier in terms of these rules really do need to be revised. I mean, they have things, I mean, for example, the right to mail never envisioned email. And we've had this issue come up with us before in terms of whether a person gets email versus mail in a psychiatric hospital. Did that mean their computer? So there is a real a need for it to be revised. I think one of the things that I highlighted in my written testimony is that the rights of recipients came out of the consent decree to the revisions. And I cited my testimony in paragraph 28. The process was that the department would submit the revisions and give them to the plaintiff's counsel, us, and to the court master. And the court master right now is Judge Wathen. And then Judge Wathen, the court master, would give his approval, and then it would go to the Maine Administrative Procedures Act. So our objection is really that it needs to follow the process in the consent decree, because it is an animal consent decree before it gets to the actual Maine Administrative Procedure Act process. But we do agree wholeheartedly. I could tell you how many things in the rights of recipients that are just outdated and aren't even used anymore. And so that is not the issue. The issue for us is really the sort of process. And the second one, I think, and I'm also going to piggyback on what Simone said, is that 2 months ago we worked out with the department these new compliance standards for the consent decree that really hone in. And I know the committee was given a presentation by Dr. Pollard about these particular standards, and the department. My understanding from the department is that they are making new platforms for data, to assess data on how the different parts of the system are operating, in terms of percentages of people who get assessed when they first present for to get an assessment for, say, ACT, or an assessment for case management. And so we think that it would be better, once we get the data from the department, a little more sample size, because we haven't even got our first sort of quarterly report from them, to look at what maybe the bottlenecks are. Is it an issue of the department in terms of how it's operating, or is it an issue with the contracts with the providers, or is it an issue with something else, before we begin trying to change the rights of recipients. So that is really, that's basically what our objection is not the need for it, but just the process where it is right now, the timing.
Thank you, Mr. Joyce. Questions for Mark Joyce? Seeing none, appreciate you being back here again today. That concludes testimony in opposition. Testifying neither for nor against is Molly Bogart.
Good afternoon, Representative Meyer, members of the committee. Once again, I'm Molly Bogart, Director of Government Relations for DHHS. I am delayed in getting you my written testimony on this. I apologize, but I will get that to you well before any work session. I am finding myself agreeing with just about everything that's been said today. I think we certainly concur that there are updates needed to this work, but also have concerns about the timeline in this bill, given the ongoing work to implement the rule changes required as part of the consent decree settlement, as well as our own plans for stakeholder engagement and looking to update these rules. And so my request to you all would be that this was carried over until next session, which would allow us to have the opportunity to implement the rule changes related to the consent decree settlement and outline a process for this updating. If that's not the pleasure of the committee, then we would certainly request an extension of the due date for these rule changes, so that we could do these in an appropriate timeline, rather than try to do them all at the same time. We also agree that consumer voices need to be an important part of this process, and so would look forward to making sure that those are included. But those are most of our comments. Again, I'll submit written testimony. Happy to answer any questions, or make myself or others from the Office of Behavioral Health available at the work session.
Thank you, Molly. Any questions for Molly? Seeing none. So I would ask, that concludes our testimony. I would ask the committee for any requests from Aaron for our work session. Not seeing any. And yes, Representative Stover.
Would it help the committee to see a copy of the rights as they exist right now?
That's posted already in your electronic LD file, both for adults and children.
I mean, I think if you looked at some of the language, you would see, and I don't think anyone's in disagreement that it's archaic and some of it's just just not even real. So I just, if people could take a look at that, I think it might help. I look forward to further discussion. And just to give it a time date, Katie Fulham Harris and I were actually working at the department when the last revisions were made, and we're part of that group. So that was a long time ago. We were very young. I'll just add that. Thank you.
Thank you, Representative. Seeing no other requests for information, I'll close the public hearing on LD 1080 and ask our analyst if there is any other business on our agenda for today.
Not that I know of, no.
Okay. With that, I would entertain a motion to adjourn.
So moved.
Second.
All in favor?